Hi, welcome to my presentation of the respiratory system. Okay, so here are the organs of the respiratory system. First, of course, you have the lungs, but then also the thoracic cage. That's considered an organ in the respiratory system. The thoracic cage includes the ribs, the muscles in between the ribs, so the internal and external intercostal muscles. Also, the diaphragm is part of the thoracic cage, and then finally, just all of the connective tissue that's holding that together. Then also you have all of the blood vessels that are in the pulmonary circuit. All of them count as part of the respiratory system, as well as part of the cardiovascular system. And finally, you have the respiratory tract. You have a couple ways of dividing the respiratory tract. It can be done anatomically or functionally. If you're doing it anatomically, the respiratory tract is divided into the upper respiratory tract and the lower respiratory tract. The upper one is about right here, and the lower one is everything beneath. So within the upper respiratory tract, you have the nose and the nasal cavity. You have the pharynx, which is the throat. You have the larynx, which is where your airway kind of diverges from the throat. Then in the lower respiratory tract, you have the trachea going down. Then the bronchial tree, where the trachea divides into two. That's where the bronchial tree begins. Airways in the lungs are called either bronchi or bronchioles, depending on how big they are. And all of that is part of the bronchial tree. So the lungs are basically almost entirely composed of the bronchial tree. Well, sorry, actually they're composed of the bronchial tree and the alveoli, which are the little sacs in the lungs where you actually have gas exchange happening. So if you cut into the lungs, and as you will see in some of the histology pictures for lab this week, it's all mostly alveoli, and then the bronchioles and bronchi up in there. You can also divide the respiratory tract based on function. So you have two different functional zones, the conducting zone and the respiratory zone. In the conducting zone, you have air moving in and out. In the respiratory zone, that's where gas exchange actually occurs. So almost all of this is part of the conducting zone. Of course, all of the upper respiratory tract is in the conducting zone. Also the trachea and almost all of the bronchial tree is part of the conducting zone. The very littlest parts of the bronchial tree do have some gas exchange, so those are part of the respiratory zone. Those would be related structures to the alveoli, and then of course the alveoli themselves. And we will go into the details on that in a moment. These are the functions of the respiratory system. Of course, it's mostly breathing, which is respiration. Actually, respiration is a bigger process that's more complicated than just breathing, which we're going to talk about on the next slide. Respiration is defined as providing your tissues with oxygen while removing carbon dioxide from the tissues as a waste product. Because carbon dioxide is an acid, if you have it in water, you're going to have hydrogen ions, which are protons released. That's going to lower the pH. That means that when you remove carbon dioxide from the blood by respiration, you're altering the acidity or the pH of the blood. So the respiratory system also has a big role to play in acid-base homeostasis. It actually works in conjunction with the urinary system to maintain the pH of the body. And we'll go into that more, of course, when we talk about the urinary system. Well, more in this chapter, more when we talk about the urinary system, and then finally at the end, again, even more when we talk about fluid and acid-base homeostasis. Then you also have some other functions that are kind of secondary functions, but they're still functions. So of course, speech or just vocalizations, that's all done by the respiratory system. Since the nose is part of the respiratory system, then smell is also a function of the respiratory system. Then if you remember, oh, well, I guess some of you didn't have A&P1 with me, so you don't remember, but we talked about the RAAS, the renin-angiotensin-aldosterone system in A&P1. If you hadn't heard about that before, we're going to talk about it again when we talk about the urinary system. But that's a hormone system that is used to regulate your blood pressure and the ion concentration of your body fluids in your blood. Angiotensin 2 is one of the main hormones in the RAAS. Whenever you release angiotensin, you actually release it in an inactive form. It has to be activated by renin to angiotensin 1, but then angiotensin 1 is still inactive. That has to be activated to angiotensin 2, which is actually active in the lungs. And it's actually the enzyme ACE, angiotensin converting enzyme, which is found in the lungs, that does that job. So you need the lungs, or you need the respiratory system in order to actually have an operational RAAS. If you're not familiar with the RAAS, actually you don't need to worry about it right now. We'll talk about it, when we talk about the urinary system. Apart from that, you also have some more functions of the respiratory system that are all related to pressure changes in the thoracic and abdominal cavities because of the action of breathing. So when you breathe in, your thoracic cavity expands, your abdominal pelvic cavity, the opposite of expands, contracts, and that changes the pressure. When your abdominal pelvic cavity volume goes down, the pressure goes up. And when your thoracic cavity volume goes up, the pressure goes down. So those changes in volume and pressure are what drive blood in the veins of the thoracic and abdominal cavities. That's the respiratory pump. Also, anytime that you're having trouble pushing something out, either urinating, defecating, or giving birth to a child, you use pressure changes in the abdominal pelvic cavity to help that happen, and the respiratory system can aid in that by reducing the volume of the abdominal pelvic cavity, increasing the pressure, and then helping you push that stuff out. So here you have respiration and the 4 processes that are actually within respiration. Since respiration is defined as actually delivering oxygen to the tissues, you can't just stop at breathing itself. So breathing itself is pulmonary ventilation. That is moving air in and out of the lungs. That's the first part of respiration. Pulmonary ventilation can be divided into inspiration, which is breathing in or inhaling, and expiration, which is breathing out or exhaling. Why we can't just use inhaling and exhaling, I do not know. Once you've got the air into the lungs, then you need to have pulmonary gas exchange, where the oxygen in the air moves into the blood and the carbon dioxide in the blood moves into the air. Then those gases need to be transported around the body, so that includes oxygen going out to the tissues in the blood. It also includes carbon dioxide coming back from the tissues in the blood and going to the lungs. And then finally, tissue gas exchange. Dropping the oxygen from the blood off at the tissues and having carbon dioxide from the tissues be picked up by the blood. So all 4 of those processes make up respiration. The respiratory system is responsible for the first 2, pulmonary ventilation and pulmonary gas exchange, and then it's the cardiovascular system that is responsible for the last 2, the gas transport in the blood and the tissue gas exchange. So first we'll go over the anatomy of the different parts of the respiratory system, then we'll talk more about respiration itself. Starting with the nose, the function of the nose is to conduct air, to bringing it into the respiratory tract. It also actually enhances your voice as you're speaking. The kind of sound vibrations will vibrate around in the nose and resonate, and that makes your voice louder, which you don't normally think about happening, of course, but you notice that your voice changes if you have your nose plugged, because it does function to enhance the voice. Then, of course, the nose functions and smell. The nose has kind of a lot of little passageways up there. As air is passing through those passageways, it gets warmed by your body temperature and also moistened. It's passing over a lot of your epithelia that are moist, and that water is evaporating and going into the air. That way you don't have cold, dry air going deeper into your body, which would be bad. And then finally, your nose, of course, is full of mucus. So as you're breathing in, any little particles, including pathogens that come in on the air, most of them are going to get caught up on the mucus and then trapped there. And then you have cilia. They're going to, well, most of the epithelial cells in the nose would be having cilia on their apical or their top surface, and those cilia are going to move the mucus out of the nose, therefore moving all those particles and pathogens that were trapped out of the nose as well. So you're kind of filtering those things out of the air that you're breathing in, trapping them in the mucus, then using the cilia to get rid of them. The internal anatomy of the nose is real complicated, and we're not going to talk about it. Most of the epithelium in there is respiratory epithelium. That's also called respiratory mucosa. The exception would be the part of the nose where you're actually smelling. That's the olfactory mucosa instead. That's right up here. The rest of the nose is lined, and the nasal cavity is lined with respiratory mucosa. Respiratory mucosa is a type of epithelium commonly found in the respiratory system. It is pseudostratified columnar epithelium. The cells have cilia on them, and you also have goblet cells interspersed throughout the epithelium. The goblet cells, remember, are little glands. They're glands that are only one cell large, and they make mucus. Right, so the mucus and then the cilia work together to trap stuff and then move it up and out. Actually, in the case of the nose, anything that's trapped is going to get moved, and the mucus itself is going to get moved to the back of the nose by the cilia. So the cilia are going to be moving everything back this way, and you'll end up kind of swallowing it. At which point it'll go down to the stomach, which is very acidic. Any pathogens that were in there are almost certainly going to be destroyed by all the acid. The other thing that could happen is that you could sneeze to get the stuff out that way. There's also some sinuses in your skull. Those are just little cavities in the skull, empty cavities. You have some right here, you have some more right here. The purpose of the sinuses is to lighten the face, lighten the skull, so it's easier for you to hold your head up. You have little passages that connect those sinuses to the nasal cavity, so that air and mucus can actually move in and out of the sinuses. So the sinuses will actually help to warm and moisten the air as it goes in. Since they can have mucus in there, they can also help filter and trap particles and pathogens. And they also play a role in enhancing the voice by resonance. They do not play a role in smell. And of course, it really sucks if they get all clogged up with mucus. Next, you have the pharynx, which is commonly known as the throat. The functions of the pharynx are pretty similar to the nose. First, warming and moistening the air as it moves into your body. Also, you have cells there. Well, you have respiratory mucosa in much of the pharynx, which means that you have mucus and you have cilia trapping pathogens and particles and kind of filtering them out of the air, moving them in this case further down to the stomach for a certain death. Of course, you also have air moving through the pharynx, and part of the pharynx, of course, opens onto the mouth, so food would be going through there. The pharynx is actually pretty big. It stretches from the very back of the nasal cavity all the way down to the larynx in your neck. All of this is the pharynx. There's 3 different regions of the pharynx. You have the nasopharynx at the top, where it's, at the back of the nose. That is respiratory mucosa, where you have the mucus and the cilia. Then you have the oropharynx at the back of the mouth, and the laryngopharynx at the back of the larynx, which the larynx is right here. So the oropharynx and the laryngopharynx are not coated with respiratory mucosa because you have food going through there. Since respiratory mucosa is pseudostratified columnar epithelium, it really isn't very thick and it's not very strong. It doesn't give good protection. Wherever you have food moving through, you need a bit more protection from, from the hard edges that might be there. So the oropharynx and laryngopharynx are lined with non-keratinized stratified squamous epithelium instead. And their job would be, in addition to all the other things, conducting food. And then finally, there's a few places where you have tonsils in the pharynx. You have a tonsil right up here in the nasopharynx, and you also have some tonsils here in the oropharynx. And as you remember, those are part of the lymphatic system, so that any pathogens that are coming in through the nose or the mouth would potentially encounter those tonsils and be exposed to the macrophages, dendritic cells, and B and T cells within them. Next, you have the larynx. The larynx is kind of where the dedicated respiratory part of the respiratory tract branches off from the rest of the stuff. So where's my pointer? There we go. Okay, cool. So at the top here, you would have your pharynx. Actually, your pharynx would include this part here. This would be your laryngopharynx. So you would have food coming down here, and then here you have the esophagus, which is where your food is going to continue on down to the stomach. So this is part of the digestive system, where the esophagus begins. As air moves in, it would be coming either from the mouth or from the nasal cavity down through the pharynx, and it's not going to continue down the esophagus. It'll instead go into the larynx to enter the trachea instead. So the larynx is where the air is being diverted from the esophagus. It has the function, of course, of letting air go through it, and again, filtering, trapping the particles and the pathogens. It also includes the vocal cords, which would be located right here. Those are necessary for speech and for making vocalizations. And then finally, you have this little flap, the epiglottis, which is going to close any time that you're eating, so that you don't swallow food and send it down into the lungs, which would be bad. So another function of the larynx is to keep the food out of the lower respiratory tract. As you can see in these pictures here, you have a buttload of cartilage in the larynx. Each little bit of cartilage has got its own name. We're not going to learn these names. I will mention that the thyroid cartilage is one of the biggest pieces of cartilage. It's on the anterior surface, and it's actually frequently visible from the outside. That is the Adam's apple. It's bigger in men, but it's actually present in women also. It's just a little harder to see. That's not on the test, actually. The epiglottis is the only piece of cartilage in the larynx that has a chance to be on the test. That is the little flap seen here in the posterior view, and here from on the side. That's a little flap that closes so that food does not go into the larynx when you're eating. In this part of the larynx that is above the vocal cords, it's possible you can have some food contacting it there. So that is lined with the non-keratinized stratified squamous epithelium. Then wherever you have your vocal cord starting and below, you have the respiratory mucosa with the mucus and the cilia. So as little particles come in, whatever particles were not already filtered out by the nose and the pharynx, a lot of them will be filtered out by the larynx. And then the cilia, they'll get trapped in the mucus there, and then the cilia will move them up to the very front part of the larynx, where you can either swallow it, sending it on down to the fiery hell of the stomach, or clearing your throat and, well, I mean, I guess spitting that crap out. I guess usually when you clear your throat, you swallow it. Yeah, that's what usually happens. Sometimes it can be good to not do that if you think you might be sick. If you just spit it out into like a tissue, then you can examine the color. If it has a color, if your mucus has a color, that's a sign of a bacterial infection. If it has no color, that doesn't mean that you're not sick. That means it's probably not bacterial. Maybe it's viral instead. Or maybe it's allergies. So now we'll go into a bit more detail with the vocal cords. The vocal cords are kind of this whole structure here. Within the vocal cords, it's actually just the vocal folds that generate speech or sound. The vocal folds are right here. They're the whitish bits. Then you have these vestibular folds next to them. The vestibular folds are part of the vocal cords, but they don't actually function to produce sound. Instead, they're just protecting the vocal folds and the rest of the larynx from food. The vocal folds themselves consist mostly of vocal ligaments, which are made of dense, regular, elastic tissue. And then on top of that, you have respiratory mucosa. So the thinness of the respiratory mucosa allows the whiteness of the elastic tissue underneath to shine or to show through. Then here you have cartilage covered in epithelium of the larynx. Here you have the epiglottis actually covered by the epithelium of the larynx. If you take away all that epithelium, you would see this. Actually, we've had the epiglottis removed here as well. Here's the thyroid cartilage of the Adam's apple. That would be kind of located around here in this image. Right. So the vocal folds are attached. The ligaments specifically are attached to this cartilage, and you also have muscles attached to the cartilage to move it, and therefore to move the vocal folds. So whenever these muscles contract, this is actually them in their contracted state. When that happens, the cartilage gets pulled taut, like so. The vocal cords also are pulled together. So they are adducted or pulled to the midline. When those muscles relax, they look more like this. The cartilage completely changes its its location, and the vocal folds abduct, so they move away from the midline or they open up. Anytime that you have air passing through here, you can have the vocal ligaments being vibrated, and that creates sound, similar to how a stringed instrument creates sound when the strings vibrate. If the vocal cords are adducted, if they're kind of pulled into the center, you get a high-pitched sound. If they are abducted or kind of opened up like that, you get a low-pitched sound. And in order to control the loudness of the sound that you make, you control that by controlling how much air is passing through. So if you have a lot of air going through, whatever sound you make will be loud. If you have a little bit of air going through, whatever sound you make will be quiet. The ligaments will have different shapes between different individuals, also between men and women, and is the shape of the ligaments or their kind of physical characteristics that determine what your voice sounds like. Most of this cartilage in the larynx, most of all of this cartilage in the larynx also actually is elastic cartilage, which means that cartilage is all going to start vibrating. When you make sounds using the vocal ligaments, all that cartilage that's elastic starts to vibrate. That enhances the sound that you make. Then, of course, it's further enhanced by the nose and the sinuses. In order to actually make speech, though, it's not enough to just have the vocal cords. You need a bunch of other structures as well. The vocal cords make sound, not speech. In order to modify that sound into speech, you need the mouth, the lips, and the pharynx, different structures in the pharynx, mouth, and lips. Next, we have the trachea. The functions of the trachea are to let air pass and to filter and trap particles and pathogens. So as you might imagine, with that function, it is lined with respiratory mucosa. The trachea has rings of cartilage going down it, or running across it, giving it its structure so that it won't be compressed, so that it can't be collapsed, which would block the airway and would kill you. Each of those rings of cartilage actually does not go all the way around. In blue here you would have the actual cartilage part. It goes most of the way around. It makes a C shape, and then at the back where the trachea touches the esophagus, this is your esophagus right here, you don't have cartilage, instead you have smooth muscle. That way, when you take a big swallow of food, the esophagus can kind of expand and can push into the trachea some. The last ring of cartilage in the trachea is called the carina, and it's kind of like this V-shaped ring. And then coming down off of that, you have the bronchi of the bronchial tree. So that marks the end of the trachea. The carina also has special sensors on it. If anything touches it, the sensors will detect the object and will make you cough. So that if you do end up having some food make it past the larynx and down into the trachea, it'll get stopped at that point. It'll most probably get caught up on the carina, and then you'll start coughing and hopefully oomph that on out. Except for the cartilage in the wall of the trachea, the walls are actually very typical for hollow organs. They have 3 layers that are typical, and then the cartilage. So the most deep layer, or the innermost layer, is the mucosa for the trachea, that is respiratory mucosa. Then beneath the, superficial to the mucosa, you have the submucosa, which is loose connective tissue. Then you have, in the trachea, you have cartilage next, and then you have the adventitia on the outside, or the most superficial layer is the adventitia. That is dense irregular connective tissue. As you remember with the blood vessels, the outermost or most superficial layer in the blood vessel wall is the tunica adventitia, or the tunica externa, and it's dense irregular connective tissue. So a bunch of hollow organs have those 3 layers: the mucosa, the submucosa, and the adventitia, where the mucosa is an epithelium that makes mucus, the submucosa is loose connective tissue, and then the adventitia is dense irregular connective tissue. Right, the dense irregular connective tissue there is just kind of holding the whole thing together, so it doesn't distend too much. The cartilage is giving it structure so that it doesn't collapse. The submucosa is bringing in blood and nutrients for the mucosa, which has no blood vessels. And the mucosa, in the case of the trachea, is producing mucus and has cilia that are moving any particles or pathogens that make it in up and out, up to the larynx, and then you would clear your throat and swallow it down. If you look at this micrograph of the tracheal tissue, here you have the respiratory mucosa. Then beneath it you have the submucosa, and then beneath that you have the hyaline cartilage. And actually on the other side of that you would have the adventitia, the dense irregular connective tissue. And that's the trachea. Next you have the bronchial tree, which is a network of airways, branching airways. starting kind of with the biggest ones, and then you have branches coming off of those that are smaller airways that are more numerous, and then those branch to get even smaller airways that are even more numerous. Alright, so every time you have a branch, the airways coming out of that branch are smaller, and of course you have more of them. These are all airways taking air deeper into the lungs, ultimately to the alveoli where gas will be exchanged. You can basically divide the airways in the lungs into bronchi and bronchioles. Then you kind of have some subtypes of those. The bronchi are the big airways. They have cartilage. The bronchioles are the small airways, and they do not have cartilage. The cartilage would be, of course, to keep them open. The functions of the bronchi and the bronchioles are to conduct air, especially the bigger ones also have a function in filtering and trapping particles and pathogens, and they also function to regulate ventilation. So they have smooth muscle around them, especially the littler ones have a lot more smooth muscle, so they can contract or dilate, and that regulates where within the lungs air is going so that you can match the air supply with the blood supply in different parts of the lungs for efficient ventilation. You start with the bronchi, of course, because those are biggest. So at the carina of the trachea, you have that branch, and you have two primary bronchi coming off of it and going into the lungs. Oh, you know, I should have mentioned before, your left-hand lung is smaller than your right-hand lung. It's got this little spot in it for the heart. Oh, you know, I didn't mention that because we didn't talk about the lungs yet. Oh, okay, well, I mentioned it now. Right, so you have your primary bronchi entering the lungs, two of them, one per lung. Then you're going to have more branches coming off of those for the secondary bronchi. So here you have a secondary bronchus. Bronchus is singular, by the way. Bronchi is plural. Here you have two more secondary bronchi on the right. Then if you look on the left, here and here are your secondary bronchi. Then those will branch again and give you tertiary bronchi, such as here, here, and here, here. About 10 of them per lung. And then you have, of course, more branching, more and more and more branching. As the bronchi branch, they get smaller and smaller. So after the tertiary bronchi, we stop tracking how many branches it's been, and they're just bronchi. Some of them are bigger, some of them are smaller. The smaller ones are always more numerous. As they get smaller, the rings of cartilage around them become wider apart so that you go a longer distance before you get to a new cartilage ring. Also, the rings become discontinuous, so they don't go all the way around the bronchi. Actually, they at the end will be just little bands, just really little patches of cartilage scattered on the bronchi, which nonetheless, even though they're so small, still help to hold the bronchi open. As you go down and the cartilage becomes less common, the smooth muscle becomes more common, and you'll have thicker bands of smooth muscle around the bronchi, and also more numerous bands of smooth muscle around them. And then the epithelium starts thinning out. So at the top, with your primary bronchi and your secondary and tertiary bronchi, you have your respiratory mucosa. So pseudostratified columnar with cilia and goblet cells, trapping particles in the mucus, and then cilia moving it up and out. As you go to smaller and smaller bronchi, you stop having respiratory mucosa at some point, and you end up with simple columnar epithelium instead. Although a lot of that does still have cilia and sometimes goblet cells. The goblet cells will become less numerous as you go. The cilia will become less numerous as you go, until you eventually end up with none of that. Eventually you get to an airway that's so small, it's not a bronchus, it's a bronchiole. The bronchioles are the littlest airways in the lungs. They're defined as not having cartilage in their walls. Instead of cartilage, they have more smooth muscle. and they don't have columnar epithelium in general. They have simple cuboidal epithelium instead, although again there's a few exceptions to that. I guess when the body's making airways, it doesn't think to itself, am I going to make a bronchus or a bronchiole? It just makes something. And then we, after the fact, try to impose these categories on it. So some of those little airways may have a little bit of simple columnar on them, but it's supposed to be simple cuboidal according to our classification scheme. And they don't have cilia, they don't have mucus or goblet cells. So hopefully you don't have any little particles that made it all the way down into the bronchioles, but if you did, they're kind of stuck there. So here you have a cast of the bronchial tree. You can see your trachea at this top, and then the primary bronchi branching to make secondary bronchi, branching to make tertiary bronchi, and then more and more bronchi. And actually, you would have the bronchioles coming off of these many little bronchioles. The bronchioles will branch and branch and branch, getting smaller and smaller and smaller every time. You have just very many of them. Actually, some of the littlest points on this cast may in fact be bronchioles. Right there and stuff. At the end of the bronchioles, you reach terminal bronchioles, which they're called terminal, not because they're actually the last bronchiole, but because they are the last bronchiole that is in the conducting zone. And you have about 30,000 bronchioles per lung, so a lot of branching there. And that's the end of the conducting zone, but the bronchial tree continues into the respiratory zone. Where's my pointer? Okay, so here you have a terminal bronchiole coming in to the respiratory zone. It's going to branch and transition into smaller bronchioles that are called respiratory bronchioles. The respiratory bronchioles are called that because they can actually have little alveoli on their sides. Little air sacs where gas exchange happens will be on the sides of the respiratory bronchioles. So that means they must be part of the respiratory zone. Then you're going to have even more branching. These respiratory bronchioles will branch to make alveolar ducts, usually a couple of ducts per respiratory bronchiole. Those ducts will also have alveoli on the sides of them, and then those ducts will be leading into alveolar sacs, which are clusters of many alveoli at the very end. And all of those alveoli, the singular for that is alveolus. All of those are little sacs where you're actually having your gas exchange. So if we look closer at the alveoli, they're really delicate and small and simple. Essentially, all of their wall is made by simple squamous epithelium. It's really as thin as it can be, which means they're also as delicate as they can be. Running over the outer surface of that simple squamous, you have bands of elastic tissue, of dense regular elastic tissue, that help them kind of expand and then go back to their original shape and size. You also have little bands of smooth muscle. That's actually not shown in this image, but you do have itsy bitsy bands of smooth muscle running across the alveoli. And finally, you have bunches of capillaries. Every alveolus is surrounded by a network of capillaries of the pulmonary circuit capillaries. So if we zoom in on these alveoli, here you have the simple squamous making up the walls. We aren't showing the elastic tissue or the smooth muscle, but you'd have little bands of that crossing the outer surface of the alveolus. And then here we have capillaries that are part of those pulmonary capillary beds running across the alveolus. Of course, if you look at it in the actual histology, it does not look this clear, but you can tell that they have really extremely thin walls. You have three types of cells in alveoli. You have type 1 alveolar cells, type 2 alveolar cells, and macrophages. The type 1 alveolar cells are the most common. They basically are all these little cells making up the simple squamous lining of the alveolus. Then the type 2 alveolar cells are not very common. They're actually cuboidal cells, not squamous, so they kind of bulge out of the wall of the alveolus. The purpose of those cells, the main purpose of them is to make a chemical called surfactant that is necessary for the alveoli to function. We'll talk more about the surfactant when we talk about ventilation, but if you don't have it, your alveoli can collapse. Surfactant is basically like a type of soap, actually. Oh, and then finally the macrophages, which would be these little blue dudes in here. No, they're not blue in real life. Those kind of just wander around in the alveolus. If they find something like a particle or a pathogen, they just eat it. They eat it up. Once they've eaten a bunch of stuff, they make their way out of the alveoli and up the bronchial tree, ultimately going to the larynx where they can be swallowed. Since a lot of what they eat is dust that you've breathed in, they're called dust cells. So macrophages that are in the lungs specifically are also called dust cells informally. Then gas exchange is occurring across what's called the respiratory membrane, which would be between an alveolus and a capillary going across the surface of the alveolus. The respiratory membrane is the barrier that gas has to cross in order to get either into the blood or out of the blood. So you have kind of three sort of layers to the respiratory membrane. First, you have the actual simple squamous cells of the alveolus, which would be the type 1 alveolar cells. And then you have on the other side the simple squamous cells making up the endothelium of the capillary. So the endothelial cells. And then in the middle between them, you have the basement membrane. The basement membrane of the alveolus and of the capillary is kind of fused together. So you get just one basement membrane for the two simple squamous epithelia. This is extremely thin, 0.2 to 0.6 microns. Which is it's very thin, you guys. It's just very, very thin. Think about a thin thing. It's way, 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 way thinner than that. It's important for it to be very thin so that gas crosses real easily. You don't want to have anything blocking the gas as it's trying to get into your body or out of your body. So the fact that it's so thin makes it easier for gas to cross. And then you just have a lot of it with all these little alveoli. The lungs are actually just, I mean, they're mostly alveoli if you look at the histology. So you have quite a good bit of respiratory membrane in there. Actually, I mean, it depends on your size, your age, your gender, but about 1,000 square feet of respiratory membrane is up inside of your lungs if you're combining two lungs together. All of that surface area is where you can have gas exchange. So the more surface area, the more gas you can get in and out of the lungs in and out of the blood in a short time period. That's crazy, you guys. That's a lot of feet. Okay, finally the lungs. All right. So now I can mention that the left lung is more smaller because of the heart. So the lungs are located in the pleural cavities, which are within the thoracic cavity. The pleural cavities are made by serous membranes, which, as you remember, are those kind of beanbag-like membranes that have the two walls. The outer wall is always called the parietal wall. The inner wall is always called the visceral wall. So for the lungs, the parietal pleural is the wall of that serous membrane that in this case would actually be touching all the thoracic cage structures and fused to those structures. Then the visceral pleural pleura is the side that's touching the lungs themselves, and it's fused to the surface of the lungs. Between those two walls of the serous membrane, you have the serous fluid. You have a little space, teensy space, that would be filled with serous fluid, which in this case is called pleural fluid because it's for the lungs. The role of that fluid is, and of the serous membranes as a whole, is to reduce friction so that as your lungs are moving, they don't rub against the thoracic cage. That would cause damage, probably to the lungs, because, you know, they're more delicate than the ribs. The lungs are lobed, so you can see here's a lobe, here's a lobe, here's a lobe, here's a lobe, here's a lobe. The visceral pleura is actually going to go down into those little fissures between the lobes, so it follows the surface of the lungs even as it goes down into lobes. Then if you look more closely at each of those lobes, you're going to find segments and then lobules. Lots of lobes within lobes in the lungs. There's a couple of special places on the lungs. Right here, this is the cardiac notch. That is where the heart would fit in its own pericardial cavity. If you look at the medial surface of each lung, you'll find the hilum. That's where everything, all these passages are entering and exiting the lungs. So all of your blood vessels going in and out, any nerves, well, your nerves that are going in and out, and the airways themselves, the primary bronchi, would be entering through the hilum. And a final thing that I'll mention about the lungs is that they have two blood supplies. Of course, your pulmonary circuit blood vessels are taking blood to the lungs, but that's for the purpose of oxygenating that blood. So that's not really designed to provide the lungs themselves with a blood supply or an oxygen supply. So first you have the pulmonary circuit arteries that bring deoxygenated blood into the lungs, and then pulmonary circuit veins that carry oxygenated blood away from the lungs to the heart. But then you also have some systemic circuit arteries that bring oxygenated blood into the lungs to supply them with nutrients. Those would be called the bronchial arteries. So remember the difference between bronchial arteries and pulmonary circuit arteries. Okay, so now we're going to go over the 4 processes in respiration, starting with pulmonary ventilation. So pulmonary ventilation, air moving in and out of the lungs, is based on pressure gradients. So anytime you have a pressure gradient, that's a difference in the pressure between 2 areas. Any substance that is subjected to those pressures is going to move from the area of high pressure to the area of low pressure. So we all probably have seen examples of this. If you've used a syringe or seen a syringe being used, when you just have liquid in the syringe, you have equal pressure inside the syringe and outside. If you're going to draw liquid into the syringe, you would pull up on the plunger. When that happens, you create extra volume in the barrel, and that extra volume is going to reduce the pressure in there, so you end up with lower pressure inside the barrel and higher pressure outside in the atmosphere. So air or a liquid, you know, whatever you're trying to suck up is going to move into the barrel. Then when you want to get it back out again, you push down on the plunger. That makes a smaller volume inside the barrel. Since the volume is smaller, the pressure is going to go up, and you're going to have higher pressure inside the barrel, lower pressure outside in the atmosphere, and whatever you had in there is going to squirt out, down its pressure gradient. This is also why we have winds. If you've ever been watching the Weather Channel, where, you know, watching the weather, and they talk about a low pressure system moving in, that means there's a part of the air where there's low pressure. The atmospheric pressure here in the low pressure area is lower than the atmospheric pressure around it. So air molecules are going to move from an area of high pressure into the area of low pressure. So that's why you're going to have all these air molecules converging around this low pressure area, and that generally would create some type of storm, or at least, winds. So the same thing happens in the lungs. Anytime you have more pressure in the atmosphere than you do inside of your lungs, air will move down that pressure gradient into the lungs. Anytime you have more pressure inside of the lungs than outside in the atmosphere, air will again move down the gradient out of the lungs. It's actually Boyles Law that kind of explains how this works. Boyles Law is a gas law. It states that at constant temperature and mass, the product of the pressure and volume of a gas is constant. So what that means, if you state it mathematically, that would be P1 V1, let's see my pointer, P1 V1 equals P2 V2, and you can illustrate it with this kind of air trapped in a little container. So if you have, a set number of molecules in this container, that's a set mass, and you're also holding the temperature constant, you're going to have a certain volume and pressure in this container. If you then reduce one or the other, you're going to increase the one that you didn't alter. So if you take the volume of this container and cut it in half, the pressure is going to have to double. In order for the product of the volume and the pressure to be the same, you have to, if you're going to decrease the volume, you have to increase the pressure. And if you do the math on this, 1 liter of volume times 100 millimeters of mercury of pressure would be 100. And in the second case, you reduce the volume by half, so now you have half a liter. The pressure doubled, so now you have 200 millimeters of mercury. Half times 200 is still 100. So the product of the pressure and the volume are the same in both conditions. If the volume goes down, the pressure will go up. If the volume goes up, the pressure will go down. It's the same thing in your lungs, and it's the same principle that a syringe operates on. When you push down on the plunger, you're reducing the volume. When volume goes down, pressure goes up. So the way that your lungs work is based on volume changes in the thoracic cavity. So you're changing the volume of the thoracic cavity, that means you're changing the volume of the lungs, and that means you're changing the pressure in the lungs. Basically the same way that a syringe works. When the volume of the chest cavity in the lungs goes up, the pressure goes down, air comes in. When the volume of the lungs in the chest cavity goes down, the pressure goes up and air goes out. We have several different pressures that we'll talk about. First, atmospheric pressure, which is just the pressure in the atmosphere caused by the weight of the air that's above you at any given point. Then you have the intrapulmonary pressure, that is basically the lung pressure. It's the pressure inside the alveoli of the lungs, so it's also sometimes called the intraalveolar pressure. So the intrapulmonary pressure would be in these little yellow sacs, the alveoli. Then you have the intrapleural pressure, which is the pressure within the pleural cavity. So here you have in kind of orange the chest wall, and then in dark blue that is the pleural cavity. If you look close, you can kind of see there's two lines of lighter blue surrounding or on either side of the dark blue. Those would be representing the parietal and visceral pleura, and between them you have the intrapleural or the pleural cavity, and you have the intrapleural pressure within that cavity. The intrapleural pressure, gosh you guys, the intrapleural pressure needs to be less than the intrapulmonary pressure. Both of them are going to be varying as you're breathing in and out, but the intrapleural pressure must always be less than the intrapulmonary pressure. If that is not the case, the lungs are going to collapse. It's actually that lower pressure in the intrapleural cavity that causes the lungs to move alongside of the chest wall. So, let me get my pointer back here. Right on the sides here we would have like the rib cage. On the bottom we have the diaphragm. The diaphragm is the main muscle of breathing, so when the diaphragm contracts, it's actually going to move down to be more flat, and the volume of the chest cavity, of the thoracic cavity, will go up. The lungs are going to expand to follow that, and that's because the visceral pleura is going to be moving when the parietal pleura moves. The parietal pleura is fused to the diaphragm in this case, so it'll move down, and the visceral pleura will move with it because of the low intrapleural pressure. It's almost like suction is created. When you're pulling down on the diaphragm, it creates suction within the pleural cavity that pulls the lungs down too. So if you don't have that, the lungs are going to collapse. So if you have a punctured lung, what that actually means is that you punctured this pleural cavity, so that the pressure in the intrapleural, the intrapleural pressure would then equalize with the atmospheric pressure, and will not be lower than the intrapulmonary pressure, and at that point the lungs will collapse. What's called a pneumothorax if you've punctured the pleural cavity. Part of the reason why the pressure is lower in the pleural cavity than in the lungs themselves is because you have the fluid that's in that pleural cavity pumped out into the lymphatic vessels constantly. So you're constantly having an outflow of fluid from there, and that creates negative pressure. You also have at the same time the walls of the chest tending to expand a little, while the walls of the lungs tend to shrink a little. So you have this pulling force on either side of the pleural cavity that reduces the pressure as well. Right, so here you have the pleural cavity with the intrapleural pressure. Here you would have the intrapulmonary pressure, and here the atmospheric pressure. Oh, so anytime that the intrapulmonary pressure is greater than the atmospheric pressure, air is going to leave the lungs down the pressure gradient until the two pressures are equal. Anytime the intrapulmonary pressure is lower than the atmospheric pressure, air is going to enter the lungs until those two pressures are equal. And neither of those things is going to happen unless the intrapleural pressure is less than the intrapulmonary pressure. So if we track pressure changes during ventilation, I'm not going to make you remember these numbers at all actually, but if you start with just kind of the lungs in a neutral position, atmospheric and intrapulmonary pressures are going to be equal. Intrapleural will be a little lower than intrapulmonary. Then as you're breathing in, you're going to be using your muscles to expand the volume of the thoracic cavity. Then due to the low intrapleural pressure, the lungs are going to follow the cavity as it expands, so the lungs are going to expand as well. Since the lungs are expanding, the intrapulmonary pressure will go down just a little bit, so now it's slightly lower than atmospheric pressure, and the intrapleural pressure is lower still. Then air is going to flow into the lungs down its pressure gradient, and you're inhaling or inspiring. Then you're going to get your lungs kind of full of air. The atmospheric and intrapulmonary pressures will be equal again. As more air enters the lungs, the pressure goes up. The intrapulmonary pressure will go up until it does again equal the atmospheric pressure. Then air will stop moving in and out, and the intrapleural pressure is still low. Then if you let that breath go, the volume of the thoracic cavity is going to go down. Here you can see it's bigger, here it's smaller. The lung volume will go down in turn. Since there's less volume, the pressure will go up. So now the intrapulmonary pressure is a little bit above atmospheric pressure. And again, just a teensy bit. Intrapleural pressure has also gone up, but it remains lower than intrapulmonary pressure. At this point, air is going to flow down its pressure gradient from the alveoli out to the atmosphere, so leaving the lungs. As the air leaves, you have the pressure in the lungs going down as well until it equals atmospheric pressure, and there you're back where you started. So here we have the muscles of ventilation. It's mostly the diaphragm, but also you have the external intercostals helping as well. Those are both muscles that help for inspiration. So In order to breathe air in, inspiration, you have to have the diaphragm and the external intercostal muscles contract. To exhale, you actually don't need to use muscles under normal conditions. So here's the diaphragm. It's like a dome-shaped muscle that's attached to the lower edge of the rib cage on all sides. Then here we have the intercostal muscles. The external intercostals are the ones on the sides here. They're running diagonally one way, and then in the middle and beneath the external intercostal muscles, you have more muscles, which are the internal intercostal muscles. The external ones are superficial to the internal ones. When these external intercostal muscles contract, they're kind of going to pull the ribs up and apart, and that increases the volume of the thoracic cavity. Then when the diaphragm contracts, it's going to kind of pull itself down or pull itself flatten itself out. And that again expands the volume of the thoracic cavity. So of course most of the expansion is coming from the diaphragm, and then you also have some additional expansion coming from the action of the intercostals. So your diaphragm and external intercostals are going to increase the volume of the thoracic cavity. So when you're breathing in, the external intercostals pull the ribs kind of up and out. The diaphragm pulls the bottom of the thoracic cavity down. The volume goes up. Because you have the visceral and parietal pleura stuck together by the low intrapleural pressure, the visceral pleural will move out with the parietal pleura, and the lungs will follow suit since they're fused to the visceral pleura, and that's going to change the volume of the lungs themselves. And therefore, since the volume goes up, the pressure will go down, air will enter the lungs. When you're going to breathe out, normally you don't need to use any muscles. All you need to do is relax the external intercostals to kind of collapse the rib cage back down a little bit and relax the diaphragm so that the bottom of the thoracic cavity moves upwards again. At that point, the volume in the lungs goes down, so the pressure goes up and air will move out. So these are the kind of primary inspiratory muscles, or the primary muscles of ventilation. These are the ones that you use every single time you breathe in and out. If you're having a hard time breathing, you're also going to use additional muscles. Okay, so here you can see volume changes in the thoracic cavity during ventilation. So you start out here between breaths in a neutral position. Your diaphragm and external intercostals are relaxed. So since your diaphragm is relaxed, it is pushing pushing up into the thoracic cavity. And since your external intercostals are relaxed, the ribs are kind of lowered and they're closer to each other. So the volume in the thoracic cavity here is low. The pressure would be equalized with the atmosphere. Then when you're going to draw in air for inspiration, the diaphragm will contract. That pulls the bottom of the thoracic cavity down and expands it. Then also your external intercostals are going to contract, lifting the ribs up and away from each other. So overall, the volume of the thoracic cavity will go up and the volume of the lungs will go up as well, assuming the intrapleural pressure is lower than intrapulmonary pressure. This is going to create a lower intrapulmonary pressure than atmospheric pressure, and air will move into the lungs. Then the pressure will equalize between the intrapulmonary, between the lungs and the air outside, so you're not going to have any more air movement. So you kind of have your breath drawn all the way in now. The diaphragm is still contracted. And the external intercostals are still contracted, so the volume of the thoracic cavity is high. And then it's time for you to breathe out or expire. So you're just going to relax everything. The diaphragm, when it relaxes, pushes back up into the thoracic cavity, reducing the volume. The external intercostals, when they relax, allow the ribs to kind of fall back down. And so overall, the thoracic cavity volume goes down. the lung volume follows suit. That means that the intrapulmonary pressure goes up and air will then move out into the atmosphere until it equalizes and you're back at your starting position. So that's if breathing is easy. If breathing is less easy for some reason, you're going to be using the accessory muscles of ventilation to create larger volume changes in the thoracic cavity. Anytime you can get a bigger volume change, you're going to get a bigger pressure change as well. Anytime you have a bigger pressure change, that gives you a steeper pressure gradient, and that means the air is going to move quicker in and out of the lungs. So again, you don't need these if your breathing is easy, but if you are kind of exercising, you're going to need more oxygen. At that point, you're going to be doing labored breathing. So you're going to be using your accessory muscles to create bigger volume changes, bigger pressure gradients, so you get air in and out of your lungs more quickly. Also, if you have any type of an obstruction in your airway, it's going to be hard to get air in and out, and you're going to need bigger pressure gradients to get enough air in and out to serve your needs. So labored breathing can also be referred to as forced ventilation, and it's ventilation that requires the accessory muscles. So you have one set of accessory muscles for inspiration. It's quite a long list, actually. This isn't even a completely complete list, you guys, but this is, the main ones. So you have your the internal intercostals, medial, only the medial ones, the ones that are closest to the sternum. They're actually not shown in this diagram, but the ones that are very close to the sternum are able to lift the ribs up and out as well, in addition to the external intercostals. Then you have the pectoralis minor, that's right here. The stratus anterior, right here. When those contract, they also can lift the ribs up and out, expanding the thoracic cavity. Then at the top you have, on the side here, you have the scalenes. In the front, you have the sternocleidomastoid. When those contract, they're going to be lifting the top ribs up. If your head is held in place, when they contract, they will lift the top ribs up. Again, increasing thoracic cavity volume. Then you also have the muscles in the back, the erector spinae muscles, that when they contract can kind of lift the ribs apart and increase the volume of the thoracic cavity. So all of those muscles can be brought into play to help you get a bigger volume increase in the thoracic cavity. That means a lower pressure, so it'll be much easier for you to draw air in. As for the accessory muscles of expiration, here are some, again, not even a complete list. You have the internal intercostals, those would be right in here. Right, so at the very edge here it's showing the external intercostals. Those are for inspiration. The medial internal intercostals those are accessory muscles of inspiration, but the other ones that are kind of on the sides, on the lateral sides, those internal intercostals, when they contract, actually pull the ribs closer together, which reduces the size of the thoracic cavity. Also, your abdominal muscles, all of them. So the obliques, the internal obliques, the external obliques, also the transverse abdominal muscles, also the rectus abdominis, the abs. Whenever all of those abdominal muscles contract, they're going to be pulling on the bottom of the rib cage, and they kind of pull it in. And they also just kind of contract the abdominal pelvic cavity as a whole, which ultimately pulls the bottoms of the rib cage in towards the middle, and that compresses the thoracic cavity. Then you also have the quadratus lumborum in the back. When that muscle contracts, it pulls the ribs down, the bottom ribs down, which again decreases the size of the thoracic cavity. So all of those muscles, when they contract in one way or another, reduce the size of the thoracic cavity. When you get a smaller volume, you're going to get a bigger pressure, and that helps you force air out of your lungs. And yeah, if you're having troubles breathing, those muscles are very important. They're very important for you. So now we'll go through the different factors that affect pulmonary ventilation. You have three main ones: airway resistance, alveolar surface tension, and pulmonary compliance. Airway resistance is really similar to vascular resistance, which, as you remember, was the force that opposes the movement of blood through the blood vessels. So airway resistance is the force that opposes the movement of air through the airways, or through the bronchial tree and the respiratory tract. So if airway resistance is low, that means it's easy to move air in and out, and that means that pulmonary ventilation is going to go up, or be high. If airway resistance increases, then pulmonary ventilation is going to decrease because it's harder to move the air in and out. Next, you have alveolar surface tension. Surface tension is kind of the pushback of a surface of a liquid when you press on it. So it's the resistance of the surface of a liquid to disruption or to pressure that's placed upon it. It actually occurs with all liquids. All liquids have some surface tension, but most don't have very much surface tension. Water has quite a lot. So here you have a glass of water, and its surface has enough surface tension that it's able to support this paperclip right on the surface. So what's happening here is that the paperclip is pushing down on the surface of the water, and the surface of the water is pushing back up and resisting the disruption of the paperclip. So you have that surface tension. Water has really high surface tension for any liquid, and you have that surface tension anywhere you have a surface of water. Inside of your lungs, it's all wet up in there. There's not like fluid in there, but all of the surfaces are moist. So on the alveoli, you have like a really thin film of water, and you're going to have surface tension of that water, which we'll go into it more in a moment, but that kind of pulls the alveoli in and tends to make them smaller. So as alveolar surface tension increases, the alveoli decrease in size, and that means that pulmonary ventilation will go down. So you have to maintain the surface tension at kind of a low level in order to have enough pulmonary ventilation. And then last we have pulmonary compliance, which is similar to blood vessel compliance. Blood vessel compliance is the ability of the vessels to stretch to accommodate more volume of blood. And pulmonary compliance is the ability of the lungs and the chest wall to stretch to accommodate a greater volume of air. When the pulmonary compliance goes up, pulmonary ventilation will also go up. That means it's easy to make changes in the volume of the chest wall and or the thoracic cavity in the lungs. If pulmonary compliance goes down, then it's going to be hard to change the volume of the thoracic cavity and therefore the lungs, or just hard to change the volume of the lungs themselves, and that's going to reduce pulmonary ventilation. Okay, so here we have airway resistance. The main thing that determines airway resistance is the diameter of the airways, of the bronchioles and the bronchi. Bronchoconstriction, just like vasoconstriction, that's when the smooth muscles around the bronchioles or the bronchi constrict, making it smaller. This isn't constriction, this is dilation. Bronchoconstriction, the smooth muscles around these airways constrict, and the airway gets squeezed, and the diameter of the airway goes down. When that happens, airway resistance is going to go up. Just like for vascular resistance, vasoconstriction increases the vascular resistance. Then you can also have bronchodilation. If the smooth muscles around those bronchioles relaxes, then the diameter of the bronchiole will go up and airway resistance will go down. So this is mostly changing in the bronchioles because that's where most of your smooth muscle is. The bronchi also have some smooth muscle, so they can change their volume or their diameter as well when the smooth muscle constricts or relaxes, but the biggest volume changes, or the biggest diameter changes are going to be occurring in the bronchioles. So that's under normal circumstances. It's the bronchoconstriction or dilation that's determining the airway diameter and therefore the airway resistance. But if things are going wrong, then you can also have obstructions in there that are also contributing to resistance by increasing it. So of course, if you have like some sort of a thing in there, that is going to be increasing resistance. But if you just have like too much mucus in your lungs, or if you have inflammation, since inflammation causes swelling, either of those things is going to reduce the diameter of the airways and increase resistance. And that's one of the main reasons why people who have like asthma or cystic fibrosis have a hard time breathing, because they have extra inflammation and mucus. Next, alveolar surface tension. So to do this, we kind of have to do a lot of review of 1306. So we'll start with the chemistry of water. Actually, let me take it back a step. Let's start with the electronegativity of oxygen and hydrogen. Electronegativity is the ability of an atom to attract electrons in towards its nucleus. Hydrogen has a low electronegativity. Oxygen has a very high electronegativity. It's actually the second highest out of any element, and the highest out of any element that's found commonly in organisms. In water, you have hydrogens attached to oxygen. So these hydrogens are bonding with oxygen and sharing electrons with the oxygen. If you didn't have any electronegativity, the electrons would be shared perfectly equally, as shown in this picture here. In reality, hydrogen pulls weakly on electrons due to its low electronegativity, but oxygen pulls strongly on electrons because of its high electronegativity. So that means that the oxygen is going to pull the electrons in towards itself. The electrons are getting farther away from the hydrogen and closer to the oxygen. When that happens, it's like this hydrogen is missing out on electrons. It's almost like it doesn't have a full complement of electrons anymore because they're so far away from it. So that gives it a partial positive charge. A partial charge is always represented with this weird, well, this weird little doodad. This is a delta. I don't know what it looks like. It looks like a funky S. So on each of these hydrogens, since they're missing electrons because the electrons are so far from them, they have a partial positive charge. On the oxygen, on the other hand, the electrons are really close to it. So since it has electrons that are extra close to it, it's like it has extra electrons almost. So that gives it a partial negative charge, since the electrons have a negative charge. So in water, you have one side of the molecule that has hydrogens and partial positive charges. On the other side of the molecule, you have oxygen and a partial negative charge. This makes water a polar molecule, and that gives rise to many of the properties of water. And one of the things it means is that water can hydrogen bond with itself. In a hydrogen bond, you just have an attraction between this partial positive charge and another partial negative charge. The partial positive charge is always on a hydrogen. The partial negative charge is either on an oxygen or a nitrogen. So if you get a lot of water molecules together, you're going to have the partial positive hydrogens on one, hydrogen bonding with the partial negative oxygens on the other, just because these opposite charges are attracting each other. It's a weak attraction because you only have partial charges. But if you get a lot of hydrogen bonds, the overall force is going to be quite strong. So if you have a sample of water here, you're going to have hydrogen bonds between the different water molecules. Every water molecule can make 4 hydrogen bonds with other water molecules. If you take a random water molecule that's down in the liquid, it'll be hydrogen bonding on all sides with other water molecules. If you look at a water molecule that's on the surface of the liquid, it can't hydrogen bond with other water molecules above it because there's nothing there. There's no water there. So it's going to make those extra hydrogen bonds side to side with the other molecules at the surface. And that is what creates the surface tension. When you have that happening inside of your alveoli, all those hydrogen bonds between the water molecules, I mean, one by one they're weak, but altogether they're really quite strong. And the alveoli have their walls are very thin, extremely thin, and they don't have like good structural support really. So if you get too much hydrogen bonding between these water molecules on the surface, if you get too much surface tension, it's going to pull the whole thing inwards, and it's going to collapse the alveolus. If that happens, that's called atelectasis. So that's different from a collapsed lung. It's not the whole lung that's collapsed, it's just the alveoli, or maybe not even all of them, but some of them. The way that your lungs prevent this from happening is using those type 2 alveolar cells that makes surfactant. The surfactant is basically like a soap. It has one side that will interact with water and another side that will not interact with water. And so it just kind of sticks itself in between the water molecules and breaks up their hydrogen bonds, and it doesn't let them hydrogen bond with each other very much. That reduces the surface tension a lot so that the alveoli can remain open and inflated. So surface tension, the alveolar surface tension shouldn't really be changing. It should be constant, and it should be low because of the surfactant. Finally, we have pulmonary compliance, which is itself determined by the alveolar surface tension, by the ability of the elastic tissue in the lungs to stretch, and by the ability of the chest wall to move. So if you have more of that alveolar surface tension, there's going to be less compliance. It's going to be harder to get the alveoli to open because they're being pulled in by that surface tension. So low surface tension would mean a higher compliance. And then the alveoli themselves and also the bronchioles and stuff, they're all coated with these bands of elastic tissue, of dense regular elastic tissue. That allows it to stretch and then bounce back. So the stretchier that stuff is, the more pulmonary compliance you're going to have. So there's some conditions like fibrosis that can degrade that elastic tissue, and that reduces the compliance. So in fibrosis, that actually means scarring. If you have damage in the lungs, you may get a scar resulting, and that means that any elastic tissue that was there is going to be replaced with dense irregular connective tissue, which does not really stretch, and that's going to reduce the pulmonary compliance significantly in that area where you have the scar. There's also some other things like smoking will damage that elastic tissue and reduce the pulmonary compliance. Then finally, the ability of the chest wall to move. So that's just your ability to get the ribs kind of moving apart from each other. Overall, pulmonary compliance should be pretty stable. It shouldn't really be changing. Yeah, because the surface tension should be stable. Just the structure of that elastic tissue and of the chest wall, it should be stable. So it shouldn't really change. If you're changing airway resistance to regulate ventilation, you're going to be doing it by bronchoconstriction and bronchodilation to change the airway diameter. Right, but if you have diseases, if you have some disease states, that can reduce pulmonary compliance, like the fibrosis or the smoking, and things that damage the elastic tissue will reduce the compliance. Okay, so next we have some volumes that we measure related to respiration. This is only a selection of them. They actually have a bunch of different volumes that they like to measure. Most of these would be measured using a spirometer, which you can see here. You basically just breathe into it, and then you see what volume this little marker raises up to when you breathe. First, you have the tidal volume, abbreviated TV. That is the volume of air that you would normally be breathing in and out, or inspiring and expiring, using just the primary muscles of inspiration, the diaphragm and the external intercostals. Once you have the tidal volume, a lot of the time they'll use that to get the minute volume, which is the volume of air that you breathe in and out within 1 minute. So to do that, you just times the tidal volume by how many breaths you take in a minute. You have something called anatomical dead space in the lungs, in the conduction zone. When you're breathing in, you have air that ends up, that you breathed in, but it ends up not making it all the way to the respiratory zone. Maybe it ends up in the terminal bronchioles or in the bigger bronchioles. So it's still in the conduction zone. So that is air that you're breathing in, but it's not air that you're actually going to use for gas exchange and for respiration. So we call that dead space. Wherever you have spaces that would fill with that type of air that will not be used for gas exchange, that's dead space. You're breathing the air in and out, but you're not getting anything out of it. So the tidal volume and the minute volume are going to be bigger than the actual volume of air that you have available for gas exchange because of the air that ends up in the anatomical dead space. So some people like to take that into account. Then you have the inspiratory reserve volume and the expiratory reserve volume, IRV and ERV respectively. That's the volume of extra air that you can breathe in or breathe out when you're doing forced inspiration and expiration. So if you're doing labored breathing, you're using those accessory muscles of ventilation, then you're going to be getting the inspiratory reserve volume and the expiratory reserve volume on top of the tidal volume. The reserve volume, or RV, is the volume of air that is left in the lungs after you have done a forced expiration. That one you cannot measure with a spirometer because it's not air that is actually coming out or to the lungs. It's staying in the lungs. So everybody's going to have some air left in their lungs after they have done, well, of course, after they've done a normal expiration, but even after they've done the forced expiration and breathed out as much as they can, there's still going to be some air left in there, and that's the reserve volume. So that air is also not really participating in gas exchange since it's not moving in and out. Then you have the forced vital capacity, or the FVC. That is the amount of air, or the volume of air, that moves in and out of the lungs when you do a forced inspiration and then a forced expiration. So if you breathed in normally, that's your tidal volume. If you do a forced inspiration and breathe in as much as you can, first you do the tidal volume, then you get your extra volume coming in, that's your IRV. And then if you breathe out for a forced expiration, then you get the ERV too. So the FVC is the TV, the ERV, and the IRV added together. And here's a graph showing those different capacities. So in the middle, here's your tidal volume. That's the amount that you breathe in and out during normal breathing, quiet breathing. If you take a forced inspiration, here's the inspiratory reserve volume. So notice it doesn't include the amount of air that you would breathe in normally. During your forced inspiration, you're breathing in the amount that you breathe in normally, and also all of this extra inspiratory reserve volume. Then here, if you do a forced expiration, here's your expiratory reserve volume. They actually indicated it over here for reasons. Right, so you would be breathing out first your tidal volume, and then you breathe out your extra expiratory reserve volume. And as you notice, that doesn't go down as high as the inspiratory reserve volume is. So that extra space there is the residual volume. That is the volume of air that's left behind in your lungs that you cannot breathe out. And then finally, your forced vital capacity is like, here it is. So that's the tidal volume and the expiratory reserve volume and the inspiratory reserve volume all added up. That's the biggest amount of volume that you can possibly get moving in and out of your lungs. So by looking at these different volumes, you can get some idea about a person's respiratory functioning. In people who have lung diseases of all kinds, or of many kinds, these volumes would be reduced versus a normal person. Okay, now we'll go over gas exchange. Actually, in the process, first you have pulmonary ventilation, then pulmonary gas exchange, then gas transport, and finally tissue gas exchange is last. So these processes happen at different points in respiration, but since they're really close to each other, we're going to talk about them together. So we're going to be talking about pulmonary and tissue gas exchange as just gas exchange. So here we have some more gas laws that come into play. First, there's Dalton's law that states that the pressure of a mixture of gases, is the sum of the partial pressure of each individual gas in the mix. So the partial pressure is the pressure that would be exerted by a particular gas in a mixture, if it was by itself in that mixture. So in this diagram here, well, I guess at the end here you have a mixture of two gases, blue and green. So here with your first gas, the blue gas, if you just had that amount of gas in this container with this constant volume, it would have, some pressure. And when you put that gas in a mix in the same container with the same volume with a different gas, it still has the same amount of pressure, but now that's called the partial pressure because you've got more than one gas in there. For the green gas, it exerts some pressure when it's by itself. When you put it in a mixture, it's still exerting the same amount of pressure. So if each of these gases is exerting a certain pressure on its container, and then you combine them together in the same volume of space, their pressures are going to add together to make the total pressure of gas in that container. In biology, we use partial pressure as a proxy for concentration, which means that when we want to talk about the concentration of a gas or how much gas you have in some liquid or tissue or something, you will usually talk about as partial pressure instead of an actual concentration measurement, because the partial pressure of the gas is related to how much of that gas you have. There's different ways to abbreviate it. In this presentation, we're using capital P to abbreviate partial pressure, but sometimes you might also see two P's, PP. So as an example, your atmospheric pressure is made up of the partial pressure of every gas that's in the atmosphere. The atmosphere is mostly nitrogen, so you have the partial pressure of nitrogen plus partial pressure of oxygen plus partial pressure of carbon dioxide, plus partial pressure of argon, plus partial pressure of every other little gas that's in there. All of that added up equals the atmospheric pressure. That's really important because, or the partial pressure is really important because when you're talking about a pressure gradient for a gas, and the gas is going to move down its pressure gradient from one place to another, it's not the overall pressure gradient that counts actually. It's the partial pressure gradient for that gas specifically. So when oxygen enters the lungs during inspiration, that's not just because the atmospheric pressure is bigger than the intrapulmonary pressure. It's because the partial pressure of oxygen in the atmosphere is bigger than the partial pressure of oxygen in the lungs. That means that the pressure gradient for different gases in a mixture can be different depending on the partial pressures of those gases. Next, we have Henry's Law, which is all about gases dissolved in liquids. Henry's Law states that how much of a gas you get dissolved in a liquid depends on its partial pressure and the solubility that it has in the liquid. So every gas has kind of an inherent solubility in different liquids depending on just on its chemical characteristics. In general, if it's more similar chemically to that liquid, then it will dissolve more readily in the liquid and have a greater solubility in that liquid. So the solubility for a given gas in a given liquid is constant. How much of the gas actually ends up dissolved in that liquid is going to be proportional to its partial pressure or depend on the partial pressure. So in my illustration here, or in this little diagram, here you have some type of gas at a pressure of 1 bar. Bar is another way of measuring pressure. It's another pressure unit. If you were to add more gas, you can see you've got a little bit dissolved there. If you were to add more gas into the container to increase the pressure to 2 bars, so doubling the pressure, then you're going to get more gas entering the liquid or dissolving in the liquid. So this law kind of explains how much gas we find in the plasma of the blood. Okay, I keep needing my laser pointer again. So here in this pie chart, you have all the gases in the atmosphere and how much of the atmosphere by percent is accounted for by that gas. So as you can see, nitrogen is by far the most common gas in the atmosphere. Then it's followed by oxygen, and then you have a good, a little bit of argon in there, a teensy bit of carbon dioxide, which is of course, unfortunately, growing year by year until we all die. And then also another little sliver for every other gas that's in the atmosphere. So nitrogen is very abundant in the atmosphere, but it actually does not have a high water solubility. It's very insoluble in water actually. It's very hard to get it to dissolve into water. So that means that you're not going to end up with a lot of nitrogen in the plasma of the blood, even though you have a lot of nitrogen in the atmosphere as a whole. So it's 78% of the atmosphere. But if you took a sample of atmosphere of, of the atmosphere, so if you took a sample of air and put it in a container with water, you would find that out of all the gases in the atmosphere that end up dissolved in the water, only 42% is accounted for by nitrogen. So it accounts for 78% of the gases in the atmosphere, but only 42% of gases in air that was dissolved in water. Then oxygen is the next most abundant gas. You have about 21% of the atmosphere being made up of oxygen. So it's kind of a medium atmospheric partial pressure, but the solubility of oxygen is a little higher than nitrogen. It's also kind of a medium solubility. It's actually 3 times as high as nitrogen solubility. So if you take a sample of air and let it dissolve in water, you're going to end up with 35% of the gas in that water being oxygen. So it's like it's enriched. You end up with less nitrogen dissolved and more oxygen, since the oxygen has a higher solubility despite the fact that it has a lower partial pressure. Then finally we have carbon dioxide, which has a very low partial pressure in the atmosphere. It accounts for very little of the atmosphere, just enough to screw us though. And it also has a very high solubility in water. As you can see, the relative solubility of carbon dioxide is 2,100 times greater than the solubility of nitrogen. So carbon dioxide dissolves in water really easily. Even though you have such a teensy-weensy amount of it in the atmosphere, 0.03% of the atmosphere is carbon dioxide. Of course, that number is changing year by year. And I'm actually not sure which year this table is even from, but let's say 0.03% of the atmosphere is accounted for by carbon dioxide. If you left air to dissolve in water, you would end up with having 23% of all the gas that dissolved into the water being carbon dioxide. So it's greatly enriched in water. So that kind of explains why we end up with a lot of oxygen entering our blood when we breathe in and not as much nitrogen. Actually, you would not, of course, be breathing in carbon dioxide, you breathe it out. So in the body, most of the carbon dioxide is coming from your own cells. They're manufacturing it as they do their metabolism, and then that's what is ending up in the plasma. But I guess it just illustrates how the partial pressure of gases along with their solubility kind of combines to create an amount of gas that will dissolve in a liquid. Okay, so here's how those gas laws contribute to gas exchange. So first, where those gases are moving depends on the partial pressure gradients. And that's Dalton's law. So if you look at the respiratory membrane here in an alveolus, on one side you have the air in the alveolus, on the other side you have the blood of this pulmonary capillary. And here you have the partial pressure gradients for oxygen and for carbon dioxide on either side of the respiratory membrane in the middle. So for oxygen, you have a partial pressure in the alveolus that's pretty high. It's around 104 millimeters of mercury. In the pulmonary capillary, it's much lower. It's about 40 millimeters of mercury. So that means that oxygen, when it crosses the respiratory membrane, is going to be crossing down its concentration gradient into the blood. It has a bigger partial pressure in the alveolus and smaller partial pressure in the blood, so it will move into the blood. For carbon dioxide, you have the opposite situation. Its partial pressure in the alveolus is about 40 millimeters of mercury. Its partial pressure in the plasma of the blood is about 45 millimeters of mercury. So you have more carbon dioxide in the blood. That's why it's going to move down its partial pressure gradient out of the blood into the alveolus. As you notice, the gradient here for oxygen is pretty steep, 104 compared to 40. That drives a strong movement of oxygen across the respiratory membrane. For carbon dioxide, the gradient is pretty shallow. It's only a 5 millimeter of mercury difference between the 40 and the 45. So based on that, you would predict that it's going to move very slowly across the respiratory membrane, but actually it moves quickly across. It crosses really well. That is explained by Henry's law. So carbon dioxide is very soluble in water. and this is a wet respiratory membrane. So it's very easy for the carbon dioxide to cross it. Oxygen has a much lower water solubility, so it's a lot harder for oxygen to actually get across the respiratory membrane than it is for carbon dioxide. So that's how you can get both of them moving across in like significant amounts, even though they have different pressure gradients. And the way the pressure gradients point for the partial pressure for each is what determines what direction each of those gases is going to move. Of course, the entry of air into the lungs itself, ventilation is explained by Boyles Law. But you also have, of course, the partial pressure gradients active there as well. It's just that they're always pointing the same direction for all of the gases involved. If you move out to the systemic circuit, to the systemic capillaries, then you'll have gases exchange between the plasma of the blood and the cells themselves. And again, the direction is determined by the partial pressure gradients. So oxygen, you'll end up, by the time you've oxygenated your blood and you're having it leave the lungs, it's going to have picked up a bunch more oxygen. So it'll have gone from 40 millimeters mercury of oxygen to 100 millimeters mercury of oxygen, and you'll have about 40 in the actual cells. So oxygen will leave the blood and enter the cells down its partial pressure gradient. And for carbon dioxide, again, you're going to have the opposite situation where you have about 45 millimeters of mercury inside of the cells and about 40 in the systemic capillary. So it's going to be crossing into the blood. The blood will pick up more carbon dioxide so that by the time you get to the pulmonary capillaries, you have about 45 millimeters, not just 40 anymore. All right, so let me just point out and underline, this is pulmonary gas exchange on the top, this is tissue gas exchange on the bottom. But the principles behind them are the same. So here are the factors that impact pulmonary gas exchange. These factors are a little bit different for tissue gas exchange, so we'll consider that separately. First, everything relies on the partial pressure of oxygen and carbon dioxide. That depends on how much oxygen and how much carbon dioxide you have in the atmosphere, and it depends on how quickly the tissues are metabolizing. The amount that you have in the atmosphere is determining the partial pressure of oxygen and carbon dioxide in the alveoli, and then how fast you're metabolizing is determining the partial pressure of oxygen and carbon dioxide in the plasma of the blood. If you're metabolizing more quickly, then you're going to have less oxygen and more carbon dioxide. So the bigger the partial pressure gradient is, the more gas exchange you're going to have. Next, you have the surface area of the respiratory membrane. That's kind of the combined surface area of all of the alveoli. So it's very large. I think, as I had mentioned earlier, 1,000 square feet, very big. And that should be basically constant. That shouldn't really change. But it can be changed by some diseases, like for instance emphysema, that causes a lot of destruction to the alveoli. And when you're losing alveoli, that means you're losing surface area on your respiratory membrane. The bigger the surface area you have there, the more places you have where gas can cross, and the more gas exchange you're going to have. Next, you have the thickness of the respiratory membrane. The thinner it is, the better for gas exchange. The more gas exchange you will have, because the gases don't have as big a distance to cross. That also should be pretty constant, and it should be very, very thin. But again, there's diseases that can change it. So lung diseases like fibrosis, pneumonia, and pulmonary edema. In fibrosis, you have scarring of the lungs that can thicken the respiratory membrane. If you have, if you end up with some dense irregular connective tissue in there, it's going to be thicker. Pneumonia and pulmonary edema are both conditions where you end up with fluid in the lungs, and that fluid is going to effectively increase the thickness of the respiratory membrane, because the gases don't have to cross just the respiratory membrane. Now they have to cross the respiratory membrane and the fluid. They have to cross through the fluid in the alveoli first. So that is going to greatly reduce gas exchange if you have an increase in the thickness of the respiratory membrane, even if it's just matter of fluid in the lungs. If you end up with fluid in the lungs, your gas exchange for oxygen is going to be impacted a lot more than your gas exchange for carbon dioxide, because carbon dioxide has a much higher solubility in water. It's going to be much easier for it to cross that fluid than for oxygen to cross the fluid. Then finally, we have ventilation perfusion matching. This is the factor that your body would actually be regulating actively to maximize the efficiency of gas exchange in the lungs. Ventilation perfusion matching means that the amount of ventilation you have to an alveolus should equal the amount of blood flow or perfusion that you have to that alveolus. So in this, in this diagram here, the air that you have coming into each lung should equal the blood that you have coming into each lung. That's matched. That's maximally efficient. Actually, usually, we would measure that using the ventilation perfusion ratio. It's abbreviated as the VQ ratio, and that should be about 0.8, not 1, which would be perfect, but it's about 0.8. You're going to have a little bit more blood flow than you have ventilation to the lungs. On average, maybe about 5 liters per minute of blood flow to the lungs versus about 4 liters per minute of airflow, giving you 0.8 for your ratio. Different diseases can impact that. If you have a blockage in an airway, that's called a pulmonary shunt. You're not going to have air entering the alveolus. You're still going to have blood flowing to it, so that is a VQ mismatch. On the other hand, if you have an embolism, a pulmonary embolism, you're going to have a blockage in the blood vessel. So you would still have air going to this alveolus, but you don't have any blood going to it, so that's another VQ mismatch of the opposite type. Anything that kind of obstructs the airways can cause a VQ mismatch as well, so that would be like asthma and COPD, even stuff like pneumonia that decreases the efficiency of gas exchange can effectively cause a VQ mismatch. And here's kind of another example of a VQ mismatch where you have still the same amount of air entering the lungs and the same amount of blood entering the lungs, but as you can see, different amounts are going to different sides. So here we're sending 1 liter of air to the right lung every minute, but 4 liters of blood. So that's not going to be very effective. You're going to have a lot of extra blood here and not enough oxygen to fill the red blood cells up. On the other side of the lung, you're getting 4 liters of air versus only 1 liter of blood. And so you're going to get a lot of extra air, a lot of extra oxygen that couldn't be taken up by a red blood cell because there's not enough of them to do it. So all of that is going to be wasted oxygen that you're not getting into your blood. And that's why it's very important for those things to match, for ventilation and perfusion to match. So your body has a couple of ways to maintain ventilation, the VQ ratio, and it'll adjust it actually for individual alveoli so that every alveolus will have the greatest VQ ratio that it can, or the most efficient VQ ratio that it can. So one thing that the body can do is change the diameter of the pulmonary arterioles depending on the ventilation of the alveoli. So if your body senses that you have an obstruction or just anything that's limiting the airflow into this alveolus, in response, the pulmonary arteriole that serves it is going to constrict. That way, less blood flows through, you have less air flowing through, and now you have less blood flowing through, so they match. On the other hand, if you have extra air going into that alveolus, a lot of air, a lot of partial pressure of oxygen in that alveolus, that's going to be sensed by the pulmonary arteriole, which is going to dilate in response. So if you're getting extra air, you're going to get extra blood to match it. You can also, or your body can also change the constriction of the airways to match the amount of blood that's coming in, or to match the perfusion. So for that, you're going to be sensing how much PCO2, how much partial pressure of carbon dioxide you have in the blood, It's just assuming if the PCO2 goes up, that means the blood flow went up as well, so the perfusion would go up. So if you have less perfusion, less blood flow through this capillary bed, the partial pressure of carbon dioxide will go down. The alveolus is going to sense that, and the bronchiole that leads to it is actually going to constrict. So now you have less blood moving through, and you have less air moving through to match it. On the other hand, if you have more partial pressure of carbon dioxide, that would mean that you had more blood flowing through the capillaries, and the bronchiole is going to dilate in response. So if you have more blood flow, it's matched with more airflow. So your body is adjusting these things constantly for all of your alveoli to get it as efficient as possible, to make the VQ ratio as close to 1 as possible, but really it ends up at 0.8, hopefully. Okay, so those were the factors that impact pulmonary gas exchange. Now we'll do the factors that impact tissue gas exchange. First, again, you have the partial pressure gradients for oxygen and carbon dioxide. In this case, that's determined by how quickly the tissues are metabolizing, but also by how much oxygen and carbon dioxide you have in your oxygenated blood. So it's depending on how efficient that pulmonary gas exchange was. Again, the bigger the steeper the partial pressure gradients are, the more gas exchange you're going to have. Next, it depends on the surface area of the capillary walls. More surface area means more places for gases to cross, so more gas exchange. And this is actually the reason why you have those branching networks of capillary beds. This is the reason why the capillary bed is a branching network. The more little vessels you have in there, the more walls you have, the more surface area for gas exchange you have. Then you have the distance that gases have to cross. That is, of course, they have to cross the capillary walls, but then they also have to go all the way to whatever cell they're going to or coming from. So the distance that the gases have to cross is going to be different from cell to cell. It's always the thickness of the capillary wall plus the distance of the cell from the capillary itself. If you have a cell that's really close to the capillary wall, that's going to have a very short distance that gases need to cross to get to it. It's going to be very easy for that cell to get oxygen and to get rid of its carbon dioxide. It's going to have very good tissue gas exchange. If you have a cell that's pretty far from the capillary, the gases have to go a long way to get to and from the blood. So it's not going to be getting very much oxygen, and it's going to be hard for it to get rid of its carbon dioxide. The most important thing there, though, is it's having trouble getting oxygen. Actually, if you're not getting oxygen, you're not making carbon dioxide. So any cell that is too far from a capillary is just going to die. That's why you have dead cells at the top of your skin in large part, and that's why you have dead cells in the interior of your cartilage. Any tissue that's not receiving much blood is going to have cells that are too far from the capillary to get efficient gas exchange. So the bigger that distance is, the less gas exchange you have. Finally, it depends on tissue perfusion, or just how much blood is flowing through the capillary beds that serve that tissue. So how much blood supply is the tissue getting? More blood supply means more gas exchange in general. Now we'll go over the gas transport in the blood, which would be actually occurring in between pulmonary and tissue gas exchange, but we're going to talk about it now. So gas transport in the blood, especially for oxygen, is really relying on hemoglobin, which is that protein that your red blood cells are filled up with, as you remember. That protein, hemoglobin, has 4 subunits. It has 2 beta subunits, 2 alpha subunits. Each subunit has a heme group, shown by the little circle. This would be a blown up view of the heme group. So you have 4 heme groups in every hemoglobin, and every heme group has an iron atom. So you have 4 irons in every hemoglobin, and it's at that iron that oxygen can bind. So if you have oxygen attached to your heme groups in the hemoglobin, that is oxyhemoglobin. If you have hemoglobin without oxygen, that's deoxyhemoglobin. Hemoglobin carries carbon dioxide as well. Carbon dioxide doesn't bind at the heme groups, but it binds on the actual protein part, so the alpha and beta chains. And once you have carbon dioxide attached to the hemoglobin, we call that carbaminohemoglobin. Actually, hemoglobin is much more important for the transport of oxygen than for the transport of carbon dioxide. Since carbon dioxide has a good water solubility, it can travel just in the blood itself more easily. Oxygen is not very soluble in water, and it's not going to be, you're not going to be able to make enough oxygen dissolve in your plasma to feed all of your cells. You need more than that, a lot more. And that's why you have hemoglobin to bind up that oxygen. So it's mostly taking oxygen around with some carbon dioxide as well. And of course, carbon monoxide can also bind the heme groups. If that happens, it's going to kick oxygen off and prevent oxygen from binding, and you're going to, well, you're going to suffocate, basically. Unless you notice what's going on in time and you can remove yourself to an environment that does not have carbon monoxide. Next. Oh, not next. Ha. Okay, so one way that we have to measure how much oxygen is on the hemoglobin is using the percent O2 hemoglobin saturation. That's abbreviated the SaO2. It can also be abbreviated as PO2 or just SO2. Yeah, different sources will use a different abbreviation, but this means oxygen saturation on the hemoglobin. If you have all 4 heme groups bound to oxygen on your hemoglobin, that is saturated with oxygen. So the SaO2 is a measure of how many binding sites for oxygen are filled with oxygen on your hemoglobin. What your SaO2 is going to depend on the partial pressure of oxygen and hemoglobin's affinity for oxygen. The affinity means how tightly does it bind. So how tightly can hemoglobin bind to oxygen? How easy is it for hemoglobin to bind oxygen? The greater the affinity, the greater SaO2 you're going to have. In general, for your oxygenated blood, you should have around 99 to 95% SaO2 at any given time. It does depend on where you measure. Of course, if you measure in your deoxygenated blood, it's not going to be that, because a bunch of the oxygen has left the blood already. Yeah. So here's a diagram showing oxygen going on and off of the hemoglobin. When oxygen attaches to hemoglobin, we call that loading. So I guess here you have your red blood cells moving through a pulmonary capillary next to an alveolus. When it starts out, it's deoxygenated, so the hemoglobin doesn't have a lot of oxygen on it, and as it moves past this alveolus, you're going to have oxygen diffusing across the respiratory membrane, entering the blood, and loading onto the hemoglobins. It can't stay in the blood because it has a low solubility, but it's going to attach to the hemoglobin and then be carried off. Then by the time your red blood cells get to the end, they are all filled up with hemoglobin, with oxygen, and your SaO2 would be very high, like at 99%. So this is in the pulmonary circulation. Then that gas on the hemoglobin is going to be transported to the rest of the circulation, to the systemic circulation. So here you have a systemic capillary, and now the oxygen needs to come off of the hemoglobin and diffuse across the capillary wall to the tissues. That's called unloading of hemoglobin. So when oxygen attaches to hemoglobin, that's loading. When oxygen detaches from hemoglobin, that's unloading. After all this oxygen has unloaded, you're just left with a little bit behind on the hemoglobin still. Okay, here we have the oxygen hemoglobin saturation curve. So the saturation of hemoglobin with oxygen depends in large part on the partial pressure of oxygen. In your pulmonary capillaries, you have a higher partial pressure of oxygen, and you're going to have loading of hemoglobin with oxygen. In your systemic capillaries, you have a lower partial pressure of oxygen. You're going to have unloading of hemoglobin instead. In addition to the partial pressure, you have a bunch of other factors that affect how much oxygen is attached to hemoglobin by affecting the affinity. So we represent that using this graph here. This is called the oxygen hemoglobin saturation curve. It can also be called the oxygen hemoglobin dissociation curve. On the y-axis, you have your SaO2, or the percent saturation of hemoglobin with oxygen. On your x-axis, you have PO2, the partial pressure of oxygen. So if you have a very high partial pressure of oxygen, you can see you're going to have a very high saturation of hemoglobin with oxygen with all the sites being filled up. If you have a low partial pressure of oxygen, you're going to have none or few sites on the hemoglobin occupied with oxygen. So you're going to have a low SaO2. The curve is shaped like an S instead of a straight line because actually the affinity of hemoglobin for oxygen depends on how many oxygens are already attached. When you start off with no, well, it's not technically shown, but if you start off with no oxygens on hemoglobin, it actually has a pretty low affinity for oxygen, which means it's hard for it to bind oxygen. It's not very good at grabbing oxygen. Once it does manage to grab its first oxygen, it becomes better at grabbing oxygen. So if you have one oxygen already, then the affinity is going to go up, and hemoglobin will easily grab another 2 and 3, another couple of oxygen molecules to have 3 out of its 4 sites occupied. Then for any individual hemoglobin molecule, it's going to be very easy to pick up the last oxygen, at which point it'll be full and it'll be saturated. But when we look at this graph, we're not looking at an individual hemoglobin molecule actually. We're looking at a representation of all the hemoglobin molecules that are in your blood. So it's a bunch of them. So, one may pick up, you're going to have some of those hemoglobins picking up the oxygen, the last oxygen, real easy. Some of them will take a little bit longer to do it, and you're going to get this curve leveling off until eventually every single hemoglobin molecule has all 4 sites attached to oxygen. In addition to the oxygen saturation being affected by partial pressure of oxygen and being affected by how many oxygens you already have on the hemoglobin, it's affected by other conditions as well. So the shape of the curve is going to change in different conditions. Oh, and actually there's one more thing I need to explain on this slide, which is this doodad here. So whenever hemoglobin doesn't have any oxygens bound to it, it looks like the deoxy, that one. That's your deoxy form of hemoglobin. You can see when it picks up oxygen to become oxyhemoglobin, the shape changes. When the shape changes like that, it's easier for it to grab more oxygens. And that's why the affinity changes depending on how many oxygens you have already. Okay, so here's the other factors that affect the oxygen saturation curve, the oxygen hemoglobin saturation curve. First, you have temperature. The more temperature you have, the less affinity hemoglobin has for oxygen. When the temperature goes up, molecules start moving faster. Actually, it's the other way around. When molecules start moving faster, the temperature goes up, because the temperature is actually just a measure of the movement of molecules. When molecules are moving fast, it's harder for them to grab each other, so the affinity will go down in high temperatures. pH and PCO2 also affect oxygen saturation on hemoglobin. So if you have a high concentration of hydrogen ions, that would be a high concentration of protons. Let's see, this H plus right here, that's a hydrogen ion, that's also a proton. That's how we abbreviate protons. The more hydrogen ions or the more protons you have, the lower the pH is and the more acidic the solution is. And if you have more of those protons, that kind of interferes with oxygen attaching to hemoglobin, so that's going to reduce the affinity. Then the partial pressure of carbon dioxide matters because if you have more carbon dioxide in the blood, you're going to make more protons. Anytime you have carbon dioxide that dissolves in the blood, it's going to end up making some protons and lowering the pH as a weak acid. So more carbon dioxide means more protons, means lower pH, means less affinity. That's actually described by the Bohr effect. The Bohr effect is the phenomenon in which if you have a greater amount of carbon dioxide in the blood, that causes the blood to be more acidic, and that reduces the affinity of hemoglobin for oxygen. Finally, the last thing that affects it is BPG, or the amount of BPG that you have. BPG stands for 2,3-bisphosphoglycerate. It could also be called DPG by different people, so a lot of sources call it 2,3-diphosphoglycerate for DPG. But in any case, BPG or DPG, it is a byproduct of metabolism. So when cells are taking glucose and breaking it down to make ATP, they will also make some amount of BPG. That BPG will bind to hemoglobin and prevent oxygen from binding, or make it harder for oxygen to bind. So more BPG means less affinity of hemoglobin for oxygen. So all of those things are reducing the affinity of hemoglobin for oxygen. That means that they are shifting the curve right. That's a right shift. So if you're in black, you have your normal oxygen saturation curve on hemoglobin. If you have anything happening that is reducing the affinity of hemoglobin for oxygen, the entire curve will shift to the right, maybe to this dotted line. Reduced affinity because of increased temperature, increased BPG, increased protons, increased carbon dioxide, all of that reduces affinity, and that reduced affinity is going to make it harder for hemoglobin to load with oxygen, so that's not good. But it also makes it easier for hemoglobin to unload oxygen, so that could be good. So when you're in the lungs, you want to load oxygen onto your hemoglobin, but when you're in the tissues, it's the opposite thing. You want to unload the oxygen from the hemoglobin so it can go to the tissues. So having more unloading is bad in the lungs for your pulmonary gas exchange, but it's good in the tissues for your tissue gas exchange. So you kind of need to have like a balance. On the other hand, if you're reducing those things instead of increasing them, if you're reducing the temperature, increasing the pH by reducing the proton concentration, reducing carbon dioxide, reducing BPG, that's going to cause a left shift on the curve. The whole curve is going to move left, maybe to this dotted line. That means that you have more affinity of hemoglobin for oxygen, so it's going to be easier for hemoglobin to pick oxygen up. That's good in the lungs, more loading, but that's bad in the tissues because it means less unloading. It means it's harder for your hemoglobin to drop oxygen off at the tissues. So you're going to want to have a balance between all of those things so you have optimal loading and unloading of hemoglobin. And this is one way that kind of pH extremes or temperature extremes can affect your body in a negative way by interfering with your ability to get oxygen on and off of hemoglobin. And then I'll just track back and talk more about the BPG. BPG, actually it's shown right here. This is the structure of BPG. You can vary how much BPG you're making with your metabolism based on how much oxygen you need. Actually in a fetus, you'll have higher BPG. I'm sorry, it's the exact opposite. In a fetus, you would have lower BPG. And that means that when the fetus's blood is kind of streaming past the mother's blood in the placenta, since it has less BPG, it's going to be easier to load oxygen onto it, and that means that it's going to be easier for the fetus to pick up oxygen from the mother's blood. Also, anytime that you need more oxygen delivered to your tissues, you're going to increase the amount of BPG that you're making to make that happen for you. You can actually increase the amount of oxygen that you're unloading at a specific place where your oxygen demands have gone up. It doesn't have to be like in the whole, like systemic wide. Actually, all of these factors vary with your metabolism. So if your metabolism goes up, you're going to make more BPG. you're going to make more carbon dioxide. When you make more carbon dioxide, you make a lower pH, and also you have chemical reactions in metabolism. All those reactions give off heat as a byproduct, so temperature will also go up if you have more metabolism. So all of these factors go up when you have greater metabolism. When you have greater metabolism, you have greater oxygen needs as well. And all of these factors are, if they go up, they are decreasing the affinity of hemoglobin for oxygen. They're causing a right shift that increases the unloading of oxygen in the tissues. So it's easier for the tissues to get that oxygen that they need. Now, carbon dioxide. So oxygen is only really transported in the blood on hemoglobin. You have a teensy bit that's dissolved in the plasma, but not a lot. Carbon dioxide is mostly transported just in the blood itself as bicarbonate. So you actually have a couple different ways, well, 3 different ways that carbon dioxide is transported. Because it has a strong water solubility, it can actually just travel dissolved in the blood directly. So 7 to 10% of the carbon dioxide that your tissues make will just travel in the blood, dissolved in the blood. Another 20% is going to enter the red blood cells and attach to hemoglobin to make carbaminohemoglobin, and it'll travel that way. And then the rest of it, about 70%, is going to enter the red blood cells and be converted to bicarbonate, and it's going to travel as bicarbonate, which is going to be dissolved in the plasma. So it's going to be converted to bicarbonate, which is the HCO3-, and then the bicarbonate will leave the red blood cell and be dissolved in the plasma. And we're going to talk more about that like right now. So in your systemic capillaries, you're converting the carbon dioxide to bicarbonate so you can transport it. In your pulmonary capillaries, the opposite thing happens because you need to get rid of it now. So you're going to take that bicarbonate, turn it back into carbon dioxide so that you can breathe it out. And here's how carbon dioxide is converted to bicarbonate in the systemic capillaries. So first you have the carbon dioxide. It got made by the mitochondria when they were doing metabolism to make ATP. It's going to leave the cells and enter the blood. It's going to enter the red blood cells. In the red blood cells, it's going to find this enzyme carbonic anhydrase. Carbonic anhydrase is going to combine the carbon dioxide with water, and that makes carbonic acid, or H2CO3. Actually, this reaction, carbon dioxide combining with water, that just happens. It doesn't need an enzyme, but if you don't have the enzyme, it's going to happen pretty slow. And you need it to happen fast, not slow. That's why you have this enzyme. Once you have your carbonic acid, immediately, right away, it's going to lose a proton if it's in water. And then you're left with this proton and with bicarbonate, or HCO3-. The proton can actually attach to hemoglobin itself. That way you don't have a big drop in the pH of the red blood cell. That would be bad. When it attaches, that's going to be kind of interfering with oxygen's attachment some. Then your bicarbonate is going to be pumped out of the red blood cell into the plasma. It's actually this protein right here, anion exchanger 1, or AE1, that is pumping bicarbonate out and bringing chloride ions in. So it's not using ATP to do that. Normally moving something out like that might cost ATP. Instead, it's using this chloride ion. So you have a lot of chloride outside of the cell and only a little bit inside. So you can let chloride flow down its gradient into the cell. And that gives you energy. This process of bringing chloride in to get bicarbonate out of the red blood cell is called the chloride shift. When that red blood cell makes its way to the pulmonary capillaries, the opposite process is going to occur. Your AE1 protein is going to reverse its direction, so now chloride is leaving the cell and bicarbonate is being brought into the cell. The proton is going to leave, the hemoglobin, so then you have protons and bicarbonate inside the red blood cell. Those are going to combine with each other to form like spontaneously to form your carbonic acid again, and then carbonic anhydrase is going to break the carbonic acid apart to give you water and carbon dioxide again. And again, that would happen even without the carbonic anhydrase, but the enzyme is just making sure that it happens real fast. Then that carbon dioxide is going to leave the red blood cell, cross the respiratory membrane, and leave in your exhalation. That bicarbonate is really important, not just because it's how carbon dioxide travels in the blood to get out of your body, but also because it's a buffer. A buffer is any chemical that is reducing changes in the pH of a solution when you add acids and bases. So normally if you have a solution with water and you add an acid to it, the pH will go down. If you add a base, the pH will go up. If you have a buffer in that solution, the pH will change only a little bit or not at all when you add the acids or the bases. So buffers are really crucial to how your body is maintaining a constant pH, which it needs to do to not die. And you have a number of buffer systems that are responsible for that. One of the most important ones is the carbonic acid bicarbonate buffer system. This is actually also the buffer system that you use in cell culture if you're growing cells in the lab. If they're kind of mammalian cells that use this buffer system, which is all mammalian cells, you're going to be providing them with bicarbonate and actually carbon dioxide so that their pH will remain stable. So if you, here we are, here's our carbonic acid bicarbonate buffer system. If you add hydrogen ions, if you add protons to the solution, well, let's see, if you add an acid to the solution, that's going to be making protons. So then you're adding protons. These protons can combine with bicarbonate to make carbonic acid. Now you've taken the protons up, that means that the pH of the solution is not going to change. The pH will only change if your hydrogen ions are changing. So when you get extra, you put them on bicarbonate to make carbonic acid. Hydrogen ions don't change, therefore pH stays the same. Let's see if the opposite situation occurs. Here it says removing an acid, but it would be the same thing if you added a base. So if you add a base, that's something that's going to find these hydrogen ions and scavenge them. It's going to take them up. A base is something that gains a proton, and a hydrogen ion is a proton. So if you're losing these hydrogen ions, you can replace them actually. Carbonic acid can dissociate to make bicarbonate and a proton. So if you add acids, you have something to take up the extra hydrogen ions, and if you add bases, you have something to replenish the hydrogen ions that were lost to the base within range. So you can keep doing that until you kind of run out of new molecules of carbonic acid and bicarbonate to do it with. But this is going to keep your pH constant in the face of a lot of acids and bases being added to the body fluids. Okay, so a little bit more about the pH and the partial pressure of carbon dioxide. If you have small variations in the amount of carbon dioxide in your body, that's not going to impact the pH very much because any changes are going to be absorbed by that buffer system, well, by the carbonic acid bicarbonate buffer system and also by other buffer systems that you have. But if you have big old changes in the amount of carbon dioxide in your body, then you're going to overwhelm your buffers. So in general, that would happen if you had a problem with breathing, if you had a problem with ventilation. So if you're breathing kind of too much, you're going to give off too much carbon dioxide, and that carbon dioxide that's the way that you're making your bicarbonate and carbonic acid. So if you're getting rid of carbon dioxide, you're actually losing your buffer, which isn't good. On the other hand, if you're not breathing enough, you're going to be hanging on to too much carbon dioxide, and it's going to make too much protons, too many protons, and it's going to overwhelm the buffer system. So in either case, it's bad. If you hyperventilate, you're going to be giving off too much carbon dioxide. You're going to be losing your buffer. You're not going to be able to release as much hydrogen ions from whatever buffer you have left. And that's going to cause the pH to go up, and you're going to have respiratory alkalosis. The alkalosis means that the pH of your blood is too high. The respiratory means that the reason your pH is too high is because you have a breathing problem. It's because of something regarding the lungs. Anytime that happens, you're going to be having some troubles. That pH difference is going to be affecting the structure of your different proteins in a way that impairs their function. It also is going to affect your oxygen delivery by changing the affinity of hemoglobin for oxygen. It's going to lead to a higher affinity and less unloading, so your tissues are going to have trouble getting oxygen off of hemoglobin. This can make you feel kind of numb and tingly. It can give you tetany, which is like when your muscles are spasming too much, so much so that they don't even actually relax and they just end up clenched, like that person's hand there. That person, if they're in tetany, is not physically capable of moving their hand from that position. It can also cause confusion, leading to coma. So if you can actually test it. If you start hyperventilating, you'll feel the numbness and the tingling. I've done it as a whoopsie, and like you feel like the tingling in your lips first. It's creepy. And then you stop. Then you stop doing it. Yes. You can also hypoventilate. If you hypoventilate, you're not breathing enough, and you're going to retain too much carbon dioxide in your blood. That means you're going to end up having more hydrogen ions released ultimately as a result of that extra carbon dioxide and the extra carbonic acid that you're making. Since you have extra hydrogen ions and they can't be taken up by a buffer, your pH is going to go down, and now you're in respiratory acidosis. Acidosis because the pH of your blood is too low. Respiratory because the problem that caused this is ventilation, the ventilation in the lungs. That's going to cause, again, problems for the protein structure, for the structure of your proteins and for your oxygen delivery. But in this case, the opposite problem for oxygen delivery, where you have more unloading and it's harder to load. So that means that when the blood gets to the lungs, to the pulmonary circuit, it's going to be hard for it to get oxygen attached to the hemoglobin. So you're going to have less oxygenated blood, a lower SaO2 when the blood goes out to your tissues. That can cause weakness in your muscles, and then kind of sedation, confusion, and also leading to coma. So don't do that neither. If you're hypoventilating, you're probably going to end up hypoxemic. Hypoxemia means not having enough oxygen in your blood. The hypo means not enough, the ox means oxygen, and the emia means in the blood. Okay, so now we've covered respiration, and we will talk briefly about how ventilation is controlled by the nervous system. It's only the nervous system that is responsible for controlling ventilation. So it's the brainstem that controls breathing or ventilation. It's both the medulla oblongata and the pons, but the main pattern generator for breathing is in the medulla oblongata. So you have the respiratory pattern generator in the medulla oblongata. In this diagram, it is shown right here as the blue oval. So you have neurons within the respiratory pattern generator that kind of fire rhythmically, kind of just spontaneously on their own. They fire rhythmically. Ultimately, they control the muscles of inspiration, so the diaphragm and the external intercostal muscles, and they cause those muscles to contract and relax in a rhythmic pattern that allows ventilation to occur. So some of the neurons in there are called inspiratory neurons, and they fire in order to cause muscle contractions so that you can breathe in, and some of them are expiratory neurons, and their job is to inhibit the inspiratory neurons so that your muscles will relax and you can breathe out. So you have the neurons that cause muscle contractions for inspiration, then you have the neurons that turn the first group off. Actually, the circuitry that controls ventilation is very complicated, you guys. So the textbook presents it like you have the respiratory pattern generator, and then separate from that you have these two other groups, the ventral respiratory group and the dorsal respiratory group. The ventral respiratory group would be here-ish, and the dorsal respiratory group is further back from it. Dorsal means back, ventral means belly. So the ventral group is actually on the anterior side of the brainstem, and the dorsal respiratory group is on the posterior side of the brainstem. So actually those would be generally counted as part of the respiratory pattern generator, not separate from it, but that's all kind of semantics. The ventral respiratory group is more responsible for directly passing the output of the respiratory pattern generator onto muscles. So it connects to these motor neurons that travel into the spinal cord and hook up with lower motor neurons, somatic lower motor neurons that are going to the diaphragm along the phrenic nerve and to the external intercostal muscles along the intercostal nerves. So that the output of the respiratory pattern generator is actually carried to the muscles of inspiration by the ventral respiratory group neurons. Then the dorsal respiratory group is more sensory. So you have sensory information coming in. Here you would have stress receptors in the lungs sending sensory information into the brain, and here you have, this would be sensory information coming from the aortic body, which does chemoreception, sensing the chemistry of the blood. So that would all be coming in to the brainstem along the vagus nerve / the glossopharyngeal nerve. Well, I guess the information from the lungs and the aortic body is going in on the vagus nerve, but you also have other chemoreceptors in the carotid artery. That information would be going in on the glossopharyngeal nerve. So that would be entering the brainstem nuclei for those two cranial nerves, and then that information would be passed down to the dorsal respiratory group, and then the dorsal respiratory group will use that information to modify the output of the respiratory pattern generator. So in general, the ventral group and the dorsal group are kind of specialized for motor versus sensory functions, but they're generally considered to be part of the respiratory pattern generator, not separate from it. Actually, if you zoom in on either one of those groups, you're going to find a lot of smaller structures within them, and the circuitry is really very complicated, and we're not going to worry about it too much. So you actually don't need to know the ventral and dorsal respiratory groups for the test. Just know the respiratory pattern generator, and that'll be fine. Then you also have parts of the pons that are involved in controlling breathing. So there's two major respiratory groups in the pons. You have the apneustic center and the pneumotaxic center. So the apneustic center is right here, and then the pneumotaxic center is above it. The apneustic center is mostly stimulatory, so it's stimulating the respiratory pattern generator to cause inspiration, and then the pneumotaxic center is doing the opposite. It is inhibitory, so it kind of fires phasically, which means on and off. Or rhythmically would be another way to say that. So I guess the apneustic center will constantly be sending on signals to the respiratory pattern generator, telling it to cause inspiration. And then periodically the pneumotaxic center will send an off signal, turning it off so that the muscles relax and you can expire. In general, if you have a greater level of activity in the apneustic center, that's going to cause deeper breathing. You're going to contract your muscles of inspiration more strongly and get a bigger volume change in the thoracic cavity and get a deeper breath in there. You're also going to stay inhaling for longer if the apneustic center is more active. In contrast, if you have more activity in the pneumotaxic center, then you're going to be expiring more frequently, and that's going to interrupt the breaths so that you won't be able to get a deep breath. You'll have shallower breaths. So again, you don't really need to know the details of that. Just know basically that the basic pattern of breathing is established by the respiratory pattern generator in the medulla oblongata, and that the depth of breathing and the breathing rate are modified by the respiratory groups in the pons. Here's a summary of that has all of the groups shown together. So here, the apneustic center is for inspiration. The pneumotaxic center is actually can do both inspiration and expiration, but mostly focused on expiration. And then here you have your medulla groups. So the respiratory pattern generator is not labeled on here because that would be including actually the dorsal respiratory groups and the ventral respiratory groups, both of them. And then also actually the nucleus ambiguous here. You don't need to know the names of these things. This is just kind of FYI so you can see all of it together. So that's the circuitry that makes the basic pattern of your breathing, and various stimuli can modify that pattern. Chiefly the central chemoreceptors and the peripheral chemoreceptors. Those are chemoreceptors that are sensing different aspects of the chemistry of your blood. I guess we went over them when we talked about the blood vessels. We'll go over them again right now. The central ones are located in the brainstem. The peripheral ones are located in the aortic body and the carotid bodies. So if I get my laser pointer, this would be the aortic body, and this is representing the carotid body. Right, so those chemoreceptors are sensing your blood chemistry, and that information is used to regulate your breathing. It's fed into the brainstem respiratory groups to regulate your breathing. You also have stress receptors in your lungs that are used to regulate breathing so you don't overinflate the lungs. So that information is also going into these respiratory groups. And we're not going to worry too much about the other stuff. Actually, your voluntary control of your breathing, right, you can of course choose to modify your breathing at will and even just hold your breath for a while. So that actually would not be going into the respiratory groups in the brainstem, it would be going past them. So this diagram is a little bit off there, but you can, in your cortex, form the intention to breathe faster or hold your breath or, you know, modify your breathing somehow, and then that information will go out from the motor cortex and it'll go straight through the brainstem and down to the muscles directly. Right, so here you would have an upper motor neuron, a somatic upper motor neuron that would go down here, straight through the brainstem into the spinal cord and synapse onto a lower motor neuron that will control either the diaphragm or the external intercostal muscles or the accessory muscles. I guess finally I'll just note that you also have, of course, your emotions affect your breathing, as you may have noticed. That would all be going through the hypothalamus. So your hypothalamus is getting information from the amygdala about your emotional state, and it would send that information into the respiratory groups of the brainstem so that you can modify your breathing in accordance with your emotions as well as with other stimuli. So going back to those chemoreceptors, they're able to sense three things about the blood: the partial pressure of oxygen, the partial pressure of carbon dioxide, and the pH of the blood, which means the hydrogen ion concentration of the blood. Your peripheral chemoreceptors are located in the carotid bodies, which are found in your neck, where the carotid arteries branch, and then the aortic bodies, which are found on the aortic arch. So these chemoreceptors are sensing all three of those things, but they're mostly responding to oxygen. And they're basically not active normally, but if your oxygen levels start dropping, if your PO2 goes down, then they are going to activate and start firing. But their sensitivity is increased if you have a fall in partial pressure of carbon dioxide or a fall in pH, which would be a rise in hydrogen ion concentration. Oh, sorry. Their sensitivity goes up with an increase in PCO2 or a fall in pH, which would be an increase in hydrogen ion concentration. Which means that they're going to respond more strongly to a drop in oxygen if you also have an increase in carbon dioxide or a decrease in pH, which would correspond to an increase in carbon dioxide. Anytime carbon dioxide goes up, pH is going to go down. if it's changing by a lot. If it's changing by a little, the buffer systems will even out the changes. So those are basically sending the information into your brain so that you will know if your oxygen levels go down, and in response, the respiratory groups, the respiratory pattern generator is going to increase your rate of breathing so that you get more oxygen. Then you also have the central chemoreceptors found in the medulla oblongata. They're shown in these yellow strips here on either side of the medulla oblongata. They are able to sense all three things as well, but the main thing that they sense is the partial pressure of carbon dioxide and the pH. So they don't sense the oxygen as much. The way that they're able to sense that is actually just because carbon dioxide can cross the blood-brain barrier. So they're not directly sensing the pH of your blood because hydrogen ions in the blood don't cross the blood-brain barrier. Carbon dioxide can cross only. So if your carbon dioxide levels go up in the blood, you're going to have more carbon dioxide crossing the blood-brain barrier into the brain. There it's going to combine with water to form carbonic acid, which is going to dissociate into bicarbonate and hydrogen ions or protons, and then those protons will be sensed by the central chemoreceptors. So anytime they're sensing hydrogen ions, that means that those ions came from carbon dioxide that was from the blood. So the main thing they're actually responding to is how much carbon dioxide in the blood, or that how much carbon dioxide you have in your blood is what is determining their level of response. If the carbon dioxide goes up in the blood, that means you're also going to have more hydrogen ions around. That means that you're going to need to breathe faster to get to blow off the extra carbon dioxide. So those central chemoreceptors are going to send their information into the respiratory pattern generator and cause it to to increase your ventilation. Overall, the central chemoreceptors are more important in the regulation of breathing than the peripheral chemoreceptors. So when your breathing rate is being fine-tuned moment to moment, that's the central chemoreceptors that are doing that. If you have kind of a big problem with your oxygenation, then your peripheral chemoreceptors are going to start firing like crazy, and that's going to be controlling the brainstem, be controlling the medulla oblongata to make you breathe faster. But in general, under normal conditions, it's the central chemoreceptors and not the peripheral chemoreceptors that are really controlling your breathing. Which means that when you feel that need to breathe, it's actually the increased concentration of carbon dioxide in your blood that you're feeling, not really the decreased oxygen in your blood. And you can actually test that yourself. If you hold your breath, if you draw in like a big breath and then hold it, and then just hold it until you feel like you would really like to breathe now, then let your breath out. You will notice relief as soon as you are exhaling your breath. So when you're exhaling, you're giving off carbon dioxide, but you're not bringing in more oxygen yet. You have to inhale to get the oxygen. So your relief comes before you get more oxygen. That means that your sense of distress is actually related to carbon dioxide levels and not to oxygen levels. So looking in closer at the central chemoreceptors, I guess I already went over some of this information, but if the partial pressure of carbon dioxide goes up, then that information will be sensed by the central chemoreceptors, and they feed it into the respiratory pattern generator, which is going to cause hyperventilation in response, in which you're going to breathe more quickly and more deeply, and you're going to blow off ultimately more carbon dioxide. Then the PCO2 will go back down, and that information will also be relayed to the RPG. On the other hand, if your PCO2 levels go down, then the RPG is going to cause hypoventilation instead. You're going to breathe less quickly and more shallowly. Shallowly. Shallower. There we go. The result of that is going to be that you're breathing off less carbon dioxide and retaining more carbon dioxide behind in the blood, hanging on to that PCO2. That way you can maintain a stable pH in your blood. So if you are having abnormal PCO2 levels, that's going to cause abnormal pH, and you're going to feel that in one way or another. It's going to be either respiratory acidosis or respiratory alkalosis. So the central chemoreceptors generally do a real good job, but if you are kind of always having elevated PCO2 or depressed PCO2, because of a disease that you have, or just because of something, then the chemoreceptors are going to habituate over time. Over time, they're going to kind of start believing that your abnormal PCO2 level is actually normal, and so they're going to stop changing your breathing to adjust it, which can be dangerous. Also, we've had a lot of opiate overdoses in the past years, and those overdoses are caused when opiates suppress the respiratory drive, basically, so that you slow down your breathing, so you start hypoventilating, and you can actually die if you don't get enough oxygen that way. The way that's happening is in part because the opiates are actually blocking the chemoreceptors, so that you don't notice. You're kind of sedated, so you're breathing more slowly and more shallowly, and your PCO2 starts to rise because you're not breathing enough, and the chemoreceptors, the central chemoreceptors that are supposed to sense that, can't do it because the opiates are inhibiting them. So they can't signal the respiratory pattern generator that it's time to breathe more now, and if no one kind of finds you, you may die. Okay, now for the peripheral chemoreceptors that are responding mostly to partial pressure of oxygen. Normally, the partial pressure of oxygen in your arteries is going to be 100 millimeters of mercury, and they're not really active at that level. And you kind of have to have a significant drop for them to really start firing. If your PO2 drops to around 70 millimeters of mercury, then they're going to start firing, and if it continues to drop to around 60, then they're really going to start firing like a lot. And they're going to send that signal into the RPG, and it's going to cause hyperventilation. They're actually also sending their signal to the pons groups as well. And ultimately, all of these signals are converging on the RPG to cause you to increase your breathing so you can increase your oxygenation. So anytime that your oxygenation is normal, like above 70 millimeters of mercury, which is not normal, it's low. Anytime it's around normal, 100, these chemoreceptors are not going to be active, and they're not being used to control your breathing. In that case, it's the central chemoreceptors that are used. It's only if your oxygen levels fall enough that the peripheral chemoreceptors will take over. This image is just showing, here's the carotid body. Here you would have kind of nerves coming out of that and going, going into the brain. Here's a zoomed in view of like some of the cell types that you have in the carotid body. Here's a capillary for the carotid body, and then this would be a sensory nerve, a visceral sensory nerve that's going into, ultimately going into the brainstem on a cranial nerve. In this case, since it's the carotid body, that would be going on the glossopharyngeal nerve. And then down here we just have some responses of the carotid body cells to oxygen levels. So wherever you have shading, the researchers restricted oxygen access to, these are rodents actually, so they restricted oxygen access to the rodents so that they would become hypoxic, and then they let oxygen return to normal. And so these researchers found that it's actually potassium channels that are responsible for the signal. So you would have these potassium channels kind of open normally. This would be the channel opening and, well, being open and potassium flowing through the channel. When you have hypoxic conditions and oxygen is falling, then those channels close and you don't have as much potassium going through the channels. That means that the membrane potential is ultimately going to rise because you're taking away this inhibitory outflow of potassium. So here you can see the membrane potential rising when the hypoxic condition is present, and then that causes the cell to depolarize, There would be these type 1 cells. There would be depolarizing and releasing neurotransmitter. So you can see these bursts of neurotransmitter released in the hypoxic condition. That transmitter is going to bind to receptors on this nerve, and then ultimately generate action potentials that go along the axon into the brain. Of course, you don't need to know that. Now for the pulmonary stretch receptors. So these are normally not active at all to control your breathing, but if you breathe in too much, if you get too big of a breath, then they're going to activate. These are stretch receptors that are found in the bronchi and bronchioles of the lungs, and they just fire anytime the diameter of those airways gets too large. If the diameter gets too large, it's possible that you could kind of blow out those airways and actually, damage them. So it's important to make sure that that doesn't happen. So this circuit diagram here is extremely complicated. You don't need to know this information. Oh no. But here in these little blue bits, that would be your bronchi and bronchioles. So you have your stretch receptors in the walls there. I guess here they've zoomed in on a stretch receptor. Anytime you take too big a breath, that would be activated. It's going to send its information in on a cranial nerve, while on the vagus nerve, that'll be fed into these respiratory groups in the medulla and the pons. And the ultimate effect of that is going to be activating your expiratory neurons wherever they may be in the RPG and in the pneumotaxic center. On the other hand, you're inhibiting the inspiratory neurons in the apneustic center and elsewhere in the RPG. So you're blocking all of the breathe-in neurons, you're turning on all of the breathe-out neurons, and ultimately you're going to stop in the middle of your breath and start breathing out. This is a reflex called the Herring-Brewer reflex. And yeah, you need it to make sure you don't breathe in too much. So this is actually relevant now with all these COVID-19 patients who need to be on ventilators. So for the ventilators, a lot of the time you're having to use pressure, a lot of pressure to get air into these people's lungs because they have a lot of fluid in their lungs. And according to Henry's law, we know that if you want to get more oxygen dissolved in fluid in these people's lungs, the only way you can do it is to increase the partial pressure of oxygen. So the way to do that would be, first, of course, you need to give them like pure oxygen to breathe. But sometimes that's not even enough for these people. So that means that now you have to increase the overall pressure that you're using to push air into their lungs, the overall pressure of the air in their lungs. That is enough to kind of force the oxygen through the fluid in their lungs so that they're actually getting enough to kind of survive, hopefully. But the problem with that is that the pressures they're having to use sometimes are so high that they're really damaging the lung tissue itself, so that when people come off of the ventilator, they're in pretty bad shape. And that would be one of the main reasons why a lot of these people are not surviving when they have to go onto the ventilator. So yeah, your Herring-Brewer reflex is pretty important. It's a good thing. Okay, and we're going to conclude with some diseases of the respiratory system. Most lung diseases are divided into two types, either restrictive diseases or obstructive diseases. In the restrictive diseases, you have less inspiration because your pulmonary compliance is decreased. We won't talk about those too much. One of the most common examples is fibrosis, right? So if you have fibrosis of the lungs, some of that elastic tissue is replaced with collagen, with a denser regular tissue, which doesn't stretch the way that elastic tissue does, and that reduces the compliance of the lungs. That means that you can't get the lungs to expand as much when you're trying to breathe in, and that means you can't get a good pressure gradient between the atmosphere and the intrapulmonary pressure, so you have trouble getting air into the lungs. Then in obstructive diseases, you have a problem with expiration, not with inspiration, and it's because you have more airway resistance, for instance, caused by some obstruction. The reason why that affects you in expiration more so than in inspiration is because normally when you inspire, your elastic tissue on the alveoli is getting stretched as they fill up with air. Then when you expire, it recoils, right? It's going to go back to its original shape. And so you have this elastic force pushing the alveoli kind of in and pushing all the bronchioles in to be more narrow when you're breathing out. So the airways are generally always a little bit more narrow when you're breathing out. So this diagram kind of shows you how it works, where you have some type of obstruction in your airway, but it doesn't go all the way across. So you're able to get some air in when you're breathing in. Then your airways are kind of expanding as the air is coming in, the alveoli are expanding. Then when you're going to breathe out, the elastic tissue bounces back and your airways all get a little smaller and more narrow, and now this obstruction is actually blocking the entire airway and you can't get this air out. So that's why your obstructive diseases are mostly affecting you during expiration. No matter what type of lung disease you have, it's going to have the same symptoms. I mean, well, there can be symptoms that are specific to your specific lung disease, but you're always going to have certain symptoms that are in common for all of them. And the main one is dyspnea, or bad breathing. The pnea means breathing and the dys means bad. That's shortness of breath, and it's a very bad feeling, you guys, as most of you, I'm sure, have had some opportunity to notice. It really induces anxiety. Being hungry sucks. It hurts, but you can kind of forget about it for a while because, actually you can live for weeks without food. Being thirsty sucks more. It's quite hard to forget about it. You can live for a couple of days without water. But breathing, if you can't breathe, it makes you panic because you're going to be dead in minutes if you can't breathe. That's a problem not in a few hours or a few days or a few weeks. That's a problem right this minute. So that is a symptom that is very difficult to live with. In general, if you have a lung disease, the dyspnea will be more noticeable when you are exercising or doing something that increases your oxygen demands. So some of the time when the disease is kind of still developing, you won't even notice it day to day. You'll only notice it if you exercise. And then you'll notice it day to day when the disease has progressed to be more serious. Also, generally in these lung diseases, you'll be coughing. A lot of the time they involve increased mucus production, and you'll be coughing a lot to clear that mucus out. And finally, depression and anxiety are associated with lung diseases, actually, with chronic lung diseases, and it's because of the shortness of breath. It makes you very anxious when you can't breathe right, and just that kind of knowledge that you can't breathe right and that's limiting your life. It's depressing, you guys. The number one cause of lung disease is smoking. Don't smoke. Do not do it. After that, you have air pollution, which actually causes a lot of lung disease. So they've actually done studies where you compare the rates of lung diseases in houses that are next to a highway versus houses that are next to a highway at a toll booth, where people are idling for a long time as they wait to pay their toll. And there's a lot more lung disease in houses that are near toll booths than houses that are near other parts of the highway, and a lot more death. So air pollution is, it's not, you don't need to be worried about it for the planet. You need to be worried about it for yourself. It's you who might suffer. Apart from that, you have genetics that either cause lung diseases or influence your probability of getting a lung disease, and then other environmental factors. So we'll go through a few of the most common lung diseases, which just happen to be obstructive lung diseases. First, you have COPD, chronic obstructive pulmonary disease. That has kind of a loose definition. It's defined as a chronic obstruction that cannot be fixed all of the way. Which means that no matter what you do, you can make it better, but you can't make it all the way better. You can't cure it. It's actually the 6th leading cause of death in the world. possibly because we're living longer, but also because our pollution just keeps going up. In general, if you have COPD, you're going to have emphysema, or you're going to have chronic bronchitis, or you're going to have both. In emphysema, you have damage to the alveoli, and especially damage to the elastic tissue in there, and that creates these kind of dead spaces in your lungs. And so you have additional anatomical dead space. So that means that when you breathe in, you're going to have air coming in here and filling up these spaces, as well as filling up the actual alveoli that you have left. But this air in here isn't doing anything. You're not doing gas exchange with this. These are not, there's not alveoli anymore. So you have a lot less surface area of the respiratory membrane that you can use for gas exchange, and a lot more dead space instead. As you can see, healthy lungs look different. So that's the emphysema part. Then the chronic bronchitis part is basically producing too much mucus or having trouble clearing the mucus, which you could have trouble clearing it if your cilia are not working right. And then you end up having mucus clog the airways, as shown here. So the mucus forms an obstruction in those airways. The emphysema, of course, actually contributes to restrictive disease as well, since it damages elastic tissue. But overall, this is obstructive. Both those conditions are caused by smoking. Smoking damages the elastic tissue in your lungs, and it damages the cilia, making it hard for you to move mucus out. And just any time your lungs become irritated, they have a tendency to start making more mucus. Yeah. It's a very bad thing. Once you get it, you'll never not have it. So you probably want to prevent it, like, beforehand. Okay, next we have asthma. Asthma is extremely common. Actually, 7.7% of US adults have asthma, and an even larger percentage of children in the US have asthma. That's because asthma rates are just going up over time, and we're not really sure why. We don't really know exactly what causes asthma, but it's probably related to pollution, you guys. So asthma is also like an immune system disorder. It's a hypersensitivity reaction in the immune system where the lungs will overreact to different triggers, and there can be a lot of triggers, like any type of allergen can be a trigger for asthma, dust, temperature, cold temperatures in the air, exercise and exertion, all of those things can potentially trigger an asthma attack. So when you have asthma, your airways are inflamed. You're kind of having like a constant innate immune system response in the lungs, causing that inflammation. So if here you would have a normal bronchiole, this is the normal bronchiole of an asthmatic, where you have this inflammation that causes the walls of the bronchiole to thicken because they're swollen. Then whenever you are exposed to the trigger, you will have an asthma attack. In the asthma attack, the smooth muscle around the bronchioles constricts, and you start producing mucus. So as you can see, there's not much air getting through there. That's a problem. So for asthma attacks, you need to have an inhaler that will cause bronchodilation to make those smooth muscles let go. But in general, to treat asthma, you're going to use things that block inflammatory mediators so you can reduce that inflammation. Inflammation in the lungs specifically is associated with bronchoconstriction and with excess mucus production. So if you can block those inflammatory mediators and reduce the inflammation, you can improve the entire situation, actually. And finally, lung cancer, which doesn't really fit into either category. It's not really restrictive or obstructive necessarily. There's lots of types of lung cancer. Every type of cell in the lungs can cause a tumor, and those are all different types of tumors, different types of cancer. And then, the tumor can be moving fast, it can be moving slow. So there's lots of different types, and they have different prognoses, which would be, the prognosis is kind of how it's expected to turn out. So some lung cancer is kind of slow moving and it's less likely to kill you. Some lung cancer is extremely fast moving and it's very likely to kill you. In general, you usually have obstructive disease symptoms with the lung cancer because the tumors are going to be blocking some of your airways, but it can also be more restrictive. So as those tumors are damaging elastic tissue in the lungs, that's going to cause restrictive disease. And it's hard to catch it because the symptoms are very general. They just look like, lung disease symptoms. And so you might think that you have asthma or that you have, your pre-COPD, or maybe you just have that bronchitis. You might not know that there's something more serious wrong with you that could potentially kill you a lot more quickly than those other things. In order to figure out what it is, you need to do scans, either CT or X-ray scans of the lungs, and that will show you the tumors. And then really you need to do a biopsy to actually know what type of cancer it is and to confirm that it is cancer and not something else. So actually my dad just had a scan of his lungs done, and they found a mass in there, and they did a biopsy of it, and happy day, it was not a tumor. It was a scar. It was a little bit of fibrotic tissue, which he said that actually everyone has some in their lungs, just a little bit. I mean, I guess the older you are, the more you would probably have. Okay, so treatment. Anytime you have an obstructive disease that is seriously restricting your airways, you can use a bronchodilator to relax the smooth muscle around your bronchioles and bronchi so that your airways will widen back up. Those bronchodilators are all stimulating beta-adrenergic receptors for the sympathetic nervous system. So you have alpha and beta receptors in the sympathetic nervous system, or that target cells use to respond to the sympathetic nervous system. They're distributed in different places throughout the body. In the lungs, you don't have the alpha receptors, you have the beta receptors. You have beta receptors on the smooth muscle in the lungs that will cause it to dilate, to relax, so that the airways will dilate when the sympathetic nervous system is active. So with the bronchodilators, you're just activating those receptors using the medicine. And your airways will pretty much immediately respond and open up. That's not really treating the disease, that's just treating the symptoms to help you breathe better. It doesn't change the course of the disease. If you have a lung disease that involves inflammation, you can use drugs that block inflammatory mediators to help it, like montelukast or corticosteroids. And those can actually impact the course of the disease by reducing the inflammation. But in general, most of these lung diseases aren't going away once you have them. Exercise actually helps almost every single patient who has a lung disease, no matter what disease it is. And it helps, it can help prevent the disease in the first place. It's really, really good, you guys, really good. So if you're a person who has, kind of a bit more advanced lung disease where exercising really aggravates the symptoms of your disease and makes it very hard for you to breathe, then you're going to want to talk with your doctor about exercising so that you can find kind of an exercise plan that is going to work for you. But it's important that you do that because it's going to improve your condition. It actually works in different ways in different people. For people who have lung cancer, exercise will still help them, but it's not necessarily, it doesn't help your body fight the tumor, but what it does do is make you stronger so that you can take more chemotherapy. And finally, it just feels like we should mention, with treatments, that we could institute public policy changes that would, reduce air pollution or make cigarettes illegal. That would save millions of lives, you guys. Oh well. Okay, that's the respiratory system.